Good afternoon and a very warm welcome to all of you. Myself, Dr. Pratima Pramanik, first year PGT of the Calcutta Homeopathic Medical College and Hospital. Today we have gathered here for our third episode of webinar series to pay homage to Dr. Christian Friedrich Samuel Hahnemann. First of all, I like to thank our principal sir, Professor Dr. Rajat Chattopadhyay sir, for organizing such a practical oriented webinar series. Today we have two webinars. At first, I request our PG coordinator, Professor Dr. Kishore Kumar Noskar sir, H.O.D of Department of Medica, for an introductory speech. Sir.
Thank you, Dr. Pratima. Myself is Dr. Kishore Kumar. Hello. Hello.
Yes, sir, you are audible.
Okay. Thank you. Thank you very much. Thank you, Dr. Pratima. Myself is Dr. Kishore Kumar Noskar, H.O.D Department of Medica and PG coordinator of Calcutta Homeopathic Medical College and Hospital. In the occasion of 8th anniversary of Dr. Hahnemann, Master Hahnemann, it is our series of webinars we are organizing in this from this college. So today we have two presentations. The first by our Professor Dr. Debashis Biswas, H.O.D Department of Obstetrics and Gynecology, on the topic of Leucorrhoea and other abnormal vaginal discharges and its homeopathic management. And it is followed by the another presentations of our respected principal sir, Professor Dr. Rajat Chattopadhyay, on the topic of latest updates on arthritis and homeopathic management. Up to 1829. A great many authors of allopathic school had been busy in demolishing the new system of our homeopathy. And it is continuing till date. Some compared Hahnemann to the devil. Some said it is as a monstrous system. There is echoing in my voice. Whether is there
Yes,
there is some problem?
Yes,
Hello, Rajat Pratima?
Yes, sir.
Because of my earphone? Okay, I'm just okay, now it's clear. My voice. Is it clear, Dr. Pratima?
Yes, sir. Now it is clear.
Okay. Thank you. So, after the appearance of organoid medicine, there are lots of criticism regarding our homeopathy, regarding our Mr. Hahnemann. Some compared Hahnemann to the devil, and some said it is a monstrous system, and some called Hahnemann some unreliable ignorance. And
Sir,
some
please
say
mute yourself from YouTube.
Hello?
Sir, please mute yourself from YouTube.
YouTube. No. There is no YouTube. হ্যালো, মানে হ্যাঁ, আমার হচ্ছে অন্য কেউ মাইক অন করা আছে। এনিবডি? আদারওয়াইজ ডক্টর প্রতিভা?
Sir, no.
It is continuing. The problem is continuing.
Yes, sir.
হ্যাঁ, মানে তোমারও ভয়েসটা ইকো হচ্ছে কিন্তু।
স্যার ইকো হচ্ছে।
ডক্টর দেবাশিস, কোন অন্য ডিভাইস কি খোলা আছে? ডক্টর দেবাশিস, তোমার অন্য কোনো ডিভাইস খোলা আছে কি?
Hello.
Yes, sir.
Hello?
There is a problem.
Where?
Sir, echoing.
না না কোনো ডিভাইস খোলা নেই তো, কিছু খোলা নেই, নো ডিভাইস ইজ ওপেন।
ওকে, আচ্ছা, আমার ভয়েসে আর কোনো প্রবলেম আছে? ইজ দেয়ার এনি প্রবলেম ইন মাই ভয়েস?
No,
It's
sir.
okay.
Not
Now?
now. It is clear. Yes, sir. Now it is clear.
Okay, I'm continuing. Some says this system of juggling and of deception, quackery, foolish mangling, an occupation for idle cobblers. What is the reaction of Hahnemann? Hahnemann reacted as, I do not know why we should fret or get angry about it. What is true cannot be betrayed into untruth. All the numerous opposition writings are merely the last shots of the enemy into the air before their ship sinks to the bottom. The truth has already extended its rays widely and shines too brightly to admit of being eclipsed. And not only that, up to 1835, there were 6 public and formal trials undertaken by different governments at Vienna, Russia, at Munich, etc., all made by allopathic physicians. Among them, Dr. Teissier, a French physician, in 1849 to 51, and deciding in favor of homeopathy. When he presented his report to the Paris Academy, he aroused a storm of protests for his fairness in admitting that there was good in homeopathy. So, what is present in organo medicine? There is so much criticism since then until date. All are unscientific, not relevant to the modern science? Not at all. The knowledge of disease, the knowledge of vital force, experimental pharmacology, knowledge of chronic disease, etc., all are not unscientific. They're much more scientific. Because at that era, at the when Hahnemann's era, the era of the extraction of humors, the treatment follows the extraction of humors by the process of extracting the humors by the process of bloodletting, extreme the perspiration, and by this process of bloodletting, this is the treatment procedure at that time. But regarding Hahnemann, the knowledge of disease, the knowledge of pathology of that era, disease is nothing but the host reaction and their expressions to the action of adverse mental, emotional, or physical factors combined with hereditary disposition. On the other hand, the concept of vital force, it is the motion of the living organism. Later, it has been supported by various contemporary physicians like famous French physician Teissier. The organisms with a vital force make a form where two are inseparable, their union constituting the living being, the individual. And regarding the knowledge of disease, the predisposing and exciting factors term change in the interior of the human organism. This internal change can only be inferred by the understanding and expressed as morbid science. But the then knowledge regarding these internal changes were based on guesswork. And the present knowledge of internal pathology can reveal the exact phenomena in such a way that the rational combinations of symptoms related to internal changes can provide the scientific value of totality of symptoms. And related to experimental pharmacology, the knowledge of drugs must be largely concerned with their physiological action. Our pathogenetic knowledge, obtained from the proving and registered, is like a picture gallery. The whole picture of the drug pathogenesis compared with the phenomena of disease and applied. And related to knowledge of chronic disease regarding the miasm, and when considered, the miasm is related to predisposing factors, the fundamental causes of disease, which can transmit generation to generation. The present scientific concept says regarding multiple factors in the form of agent, host, and environment in relation to biological, nutrient, chemical, physical, mechanical, psychosocial, cultural, even hereditary factors, etc. And among them, as per recent opinion, the hereditary factor is the most prominent or fundamental cause, as Hahnemann indicated. And it is directly related to, as we know, the susceptibility of the individual to the adverse environment. So all are truly the scientific. Even if we see the scientific background, the scientific thoughts, today's thought, it is relevant and very much relevant. So now, in our today's presentations, first presentation of Professor Dr. Debashis Biswas, H.O.D. Department of Obstetrics Gyne, on the topic of leucorrhea and other abnormal vaginal discharges and its homeopathic management. Dr. Debashis Biswas, please start your presentation.
Thank you so much, Kishore sir.
Thank you, Dr. Kishore Nashkar, sir. Today, our topic of discussion is leucorrhea and other abnormal vaginal discharge and its homeopathic management. Am I audible and visible?
Yes, sir. We
Okay.
can hear you.
Okay. Now, before going to the topic, we should have an idea about what we mean by leucorrhea. What do we should mean by the leucorrhea? By definition, leucorrhea is strictly defined as an excessive normal vaginal discharge. So, normal vaginal discharge. This one is very important. The term leucorrhea should fulfill the following criteria. Number one, the secretion must be excessive. The excessive secretion is evident from persistent vulval moistness or staining of the undergarments, brownish yellow on drying, or need to wear a vulval pad. This is number one criteria. Number two criteria, it should be non-purulent and non-offensive, and it is non-irritant and never causes pruritus. So from this standard definition, it is clear that leucorrhea means the normal vaginal discharge. But being the homeopathic physician, we should mention that in our materia medica, all the vaginal discharges, the normal as well as abnormal vaginal discharges, are termed as leukorrhea. The reason behind this is at that time when those drug proving was done, when those America was constructed, then the leukorrhea denotes in general any vaginal discharges, excessive vaginal discharges, whatever normal, whatever abnormal, all were included under heading of leukorrhea. Even in present finding, even in the present dictionaries, the Webster dictionaries or other old dictionaries, even some articles, present articles also considered the any vaginal discharge under the heading leukorrhea. But by definition, leukorrhea should be the normal vaginal discharges and others are abnormal vaginal discharges. So, what are the causes of the normal excessive vaginal discharges which are non-purulent, non-offensive, which may be non-irritant and never causes pruritus? Now, these are the causes of normal vaginal discharges. During puberty, the increased level of endogenous estrogen, the hormone estrogen, leads to marked overgrowth of the endocervical epithelium, which may encroach to the ectocervix. The squamous epithelium of the ectocervix is replaced by the columnar epithelium of the endocervix and thus produces cervical erosion or cervical ectopy, and this in turn produces excessive secretion during puberty. This is quite normal. During menstrual cycle, around ovulation, what happens? Again, under influence of the hormone estrogen, there is excessive mucoid normal vaginal discharge. Premenstrual pelvic congestion and increased mucus secretion from hypertrophied endometrial glands occurs during the menstrual cycles. So these all things occurs under influence of the estrogen. And during pregnancy, again, there is excessive estrogen production, which along with there is increased vascularity of the pelvic organs, which leads to excessive vaginal discharge during pregnancy. And during sexual excitement, there is abundant secretion from the Bartholin glands. Next, the cervical causes of normal secretion. Cervical causes of are the cervical ectopy or the cervical erosion. Number 2, chronic cervicitis. Number 3, mucus polyp of the cervix. Chronic cervicitis secretion may be offensive, non-purulent, non-offensive also, and even in chronic cervicitis there may be normal secretion, excessive secretion also. And cervical ectropion or the eversion of the cervix, where the cervical glands are exposed to vagina, and the cervical ectropion or eversion of the cervix is commonly a result of prolonged suffering from chronic cervicitis, where the cervical mucosas, which prevents in the inner part of the cervix, endocervix, which protrudes out and it appears like the eversion of the cervix, and there is excessive vaginal discharge from the cervix. Next, so vaginal causes of normal vaginal discharge. So vaginal transudation occurs in this condition in following conditions like the uterine prolapse, and in cases of the acquired retroverted uterus, it may occur in the chronic pelvic inflammation. Those women who uses oral contraceptive pills for long time, they have the cervical causes, again estrogen, hyperestrogenism, and again there is the excessive vaginal discharge and vaginal adenosis and ill health. Now, next slide. This is very important. We have categorized this infectious causes, the causes of abnormal vaginal discharge, under 4 headings. Number 1 is infections. Number 2, due to some irritations, that are irritants. Then medical conditions and surgical conditions. So commonly the common cause of abnormal vaginal discharge is the infection. For if we told about the infection which causes the excessive vaginal discharge, first of all, we should name the Trichomonas vaginitis. It is caused by a pear-shaped anaerobic unicellular flagellated protozoa that is named Trichomonas vaginalis. It is a protozoa. Its shape is pear-shaped flagellated. It is a STD. It is a sexually transmitted disease, usually transmitted from the male partner. Common site of harbor in the male body is the urethra and the prostate, and other contaminated toilet article may also causes this Trichomonas vaginitis. So Trichomonas vaginitis is one of the common infection that causes abnormal vaginal discharge. So what is the character of the Trichomonas vaginitis affections discharge? The discharge of Trichomonas vaginitis affection is usually gray, yellow, or green color. This is maybe frothy, and this is associated with pruritus and dysuria. So next comes moniliasis or monilus vaginitis. Next come moniliasis or monilus vaginitis. This is the affection that is caused by a fungus called Candida albicans. Candida albicans is a popular fungus. It can produce all sorts of affections in in different parts of the organisms. And Candida albicans produces moniliasis. Moniliasis, Candida albicans, is a gram-positive yeast-like fungus. Moniliasis occurs. Those person moniliasis affects those persons who are suffering from some immunocompromised disease, diabetes mellitus, who are uses steroid for long time uses steroids, long use of the antibiotics, long uses oral contraceptive pills. Those women having the thyroid and the parathyroid disease, obesity, are the risk factors for the monilial affection. So being the homeopathic physician, when the patient comes with those affections and the characteristic discharge of the moniliasis, then we can suspect the affection is due to moniliasis. So moniliasis is a common organism which produces one of the common organism, and these are the high risk persons, high risk women who may develop the Candida albicans affections. Next group is bacterial vaginosis. Bacterial vaginosis, again, it is an STD. Bacterial vaginosis is an STD, and bacterial vaginosis is an STD. It is believed that it was produced by the Haemophilus vaginalis. But presently it told that it is due to some affections of the multiple organisms like bacterioid species, like Peptococcus, Mycoplasma, etc. So these are the bacterial vaginosis. This is an STD. So when the patients come from, to a homeopathic physician, patients come from the different level of the societies. If the patients are sexually active, having multiple sexual partners, those are coming from the red light areas, those are complaining of the excessive abnormal vaginal discharge, in those women we can suspect the affections of the Trichomonas vaginalis or the bacterial vaginosis, or there may be the gonorrhea, chlamydia, trachomatis affections. Again, among the infection group, next comes the acute cervicitis. Acute cervicitis is mainly due to the gonorrhea and chlamydia affections. And in chronic cervicitis, the chronic cervicitis is the commonest presentation of cervical lesion, with which the patient comes in the gynecological OPD. The endocervix, what happened? The endocervix is the natural harbor, natural residence of certain microorganisms, certain microorganisms like Neisseria gonorrhoeae, Chlamydia trachomatis, HPV virus, Mycoplasma, and also the organism that produces bacterial vaginosis. And if there is any loss of defense, like following abortion, following DNC operations, when the defense is lost, then they may produces the inflammation, and which ultimately leads to chronic cervicitis. And other group is non-specific infections. So these are few common microorganisms which infected the cervix and vagina and produces excessive vaginal discharge. Now irritants. Some irritants like the foreign body, forgotten pituitary tampon, and mechanical irritations. These are common among the children. And next, irritation with the thread worm. Thread worm irritation in this third world country, in this tropical country, the trichuria affection is very common. And sometimes patient comes with this excessive abnormal vaginal discharge and complaining of the itching is there, pruritus is there. On examination, on taking the history, we can see the patient is suffering from the thread worm irritation. And with the worm medicines, when the worms irritation subsides, then the leukorrhea automatically subsides. So when we do the clinical practice in the tropical countries, in third world countries, we should keep in mind about the thread worm, particularly in children and women who belongs to low socioeconomical condition, ill health, unhygienic lifestyle, etc. Now, patient uses vaginal douches. Some patient have allergy to latex condom. Some patient uses detergent, deodorant, and too much, and the patient may have the allergy to those, and this causes the chemical irritation and allergy and causes excessive vaginal discharge. Next come contamination of urine and feces, sometimes produces secondary vaginitis, and this secondary vaginitis may often causes the abnormal vaginal discharge. Now comes to medical condition, ill health and malnutrition. Ill health and malnutrition is one of the very important cause of the abnormal vaginal discharge, excessive vaginal discharge in the third world countries like India, in our developing countries, in the developing countries like India and Bangladesh, Pakistan, etc., where the many women are suffers from the malnutrition, anemia, etc. Few studies have been conducted on the leukorrhea. I can mention one study in 2005 which was conducted in Nagpur. I can recall that in that study I have found in this, you can find this in the internet, that it has been observed that the most of the patients suffering from the leukorrhea and abnormal vaginal discharge belongs to the low socioeconomic condition, malnutrition, and unhygienic lifestyle. Next, atrophic vaginitis in postmenopausal women. In postmenopausal women, there is loss of defense, the vaginal pH changes, and the patient suffers from atrophic vaginitis, and this causes little abnormal vaginal discharge with irritation. Diabetes mellitus, it is a medical condition, and those women suffering from diabetes mellitus are more prone to get affections with the Candida albicans. Now, some surgical conditions are there. Surgical conditions where there is abnormal vaginal discharge in cases of the fibroid polyp, the discharge from the uterus and the cervix. Now, genital malignancy, cervical intraepithelial neoplasia, and CS cervix. This one is another very alarming thing, cervical intraepithelial neoplasia, and CS cervix. So whenever the patient comes to our clinic, so we should aware about the cervical intraepithelial neoplasia. So we all know the cervical intraepithelial neoplasia is usually found around the age of 20 to 30. The type 1, stage 1, stage 2 cervical intraepithelial neoplasia, where the part of the epithelial cell is affected. This was found in around the 20 to 30. And then the stage 0 carcinoma in situ usually occurs in around the age 40. So cervical intraepithelial, for the diagnosis of the cervical intraepithelial neoplasia, we will discuss it in later also. We should advise all the patient to have pap smear, cervical and vaginal pap smear. If there is atypical cytology in pap smear, then we can suspect the patient is suffering from cervical intraepithelial neoplasia. Cervical intraepithelial neoplasia is a precancerous condition, but it does not mean that patient is suffering from the carcinoma. If there is atypical cells in pap smear, then that means the patient may produce a cervical carcinoma in her later life. So here the homeopathic physicians have lots of scopes. So in this 10 years, 20 years, we have time. And in rural areas in India, many physicians treated unknowingly the patients suffering from abnormal vaginal discharge, having atypical cytology, cervical cytology, pap smear positive, and with homeopathic medicine the patient gets cured. So here is one area where we can do one study. Suppose for 6 months, 3 months study, if the patient with abnormal pap smear and the patient having abnormal pap smear, and we do homeopathic medicines, and what happened we see after 6 months, because the CIN patient does not means they are immediately they produce a CS cervix. So and this is a very good places where the homeopathic medicine acts. And in rural area of India, the many doctors, many homeopathic physicians are treated such type of cases with success, but we have no records, unfortunately. Now the endometrial carcinoma, high drops tubal profilans, old incomplete abortion, molar pregnancy, old incomplete abortion, or the missed abortion. There is vaginal discharge, yellowish vaginal discharge, continuous vaginal discharge, molar pregnancy, retained placental bits, and following cervical cautery or cryosurgery, there may be excessive vaginal discharge there. Now, in brief, these are the few causes of abnormal vaginal discharges. Now, how we should proceed, how we should, being the homeopathic physician, how we should investigate a case of increased vaginal discharge, how we should investigate a case of abnormal vaginal discharge. So first of all, symptoms are to be noted properly, because symptoms are the thing which helps us to select the homeopathic medicine. Then age, marital status, sexual history, and parity. This one is very important. This age, sexual function, these all have been mentioned in our accessory circumstances. These are also influences the woman in developing the uterine affection or cervical affection or vaginal affection, and that and produces abnormal vaginal discharge. So as for example, the patients, sexually active patients who are who have the multiple sexual partner, who has the early age of sexual intercourse. Yes, one these things. Those women who have the early age of the sexual intercourse, teenage childbirth, and who have cigarette smoking habit, they are more prone to develop the bacterial vaginosis, and in later life they are more prone to develop the cervical carcinoma and cervical intraepithelial neoplasia also. So how the sexual history is also helps us in the diagnosis or to complete the portrait of the patient. Marital status is also an important thing, whether when they got married, first exposure to sexual intercourse, if it is in the teenage below the 20 years, then those women are more at risk to develop the CS cervix in later life after 40-50. Then if the husband has the second marriage and the first marriage died of CA cervix, then the second wife is more likely to develop the pap smear positive and CA cervix in later life. And next comes to menstrual history. Menstrual history, the abnormal bleeding is there, the nature of the bleeding, whether heavy bleeding, intermenstrual bleeding, postcoital bleeding, and the relation to the menstruation, the before, after, during, etc. Now we should have to take a note of the details of the discharge, the duration, presence of itching, associated dysuria, dyspareunia, pelvic pain, smell of the discharge, color of the discharge, constituency, and any exacerbating factors are to be noted, because these points are helps to make the vaginal discharge characteristic. So these are the very differentiating point, individualizing point, that which makes the vaginal discharge characteristic and helps to complete the totality of the symptoms. So here we find the how the accessory circumstances and total menstrual history details of the discharge helps in the investigations of the abnormal vaginal discharge. Now goes to the character of the discharge. Now we goes to the character of the discharge. In cases of the trichomonas vaginalis, the characteristic discharge is frothy, gray yellow or green, with associated with excessive itching, and the patient may have dysuria. And in cases of the Candida albicans affections, the discharge is card-like, cardy white in flex and pruritic, associated with itching. So in cases of the trichomonas vaginalis affections and the Candida albicans vaginas, that is moniliasis affection, the patient comes with vaginal discharge and itching, and in cases of the bacterial vaginosis, the discharge is gray white in color, and the discharge has the fishy odor, and discharge is usually non-pruritic. And cervicitis, chronic cervicitis, the discharge is mucoid or mucopurulent. And if there is irritation from the foreign bodies like the forgotten pessary, etc., then the character of the discharge is offensive, copious, purulent, and often blood-stained. Next, if the patient is postmenopausal woman, the discharge, the postmenopausal woman usually suffers from the atrophic vaginitis. In case of the postmenopausal woman, the discharge is not prominent, but irritation is very much prominent. The patient suffers from excessive irritation, burning, dryness of the vagina, difficulty in walking due to pain and irritation. But discharge is there, but discharge is not much prominent. Discharge is there, but discharge is not prominent. The irritation is prominent. And if there is chemical irritation, chemical reaction, the patient uses detergent or deodorant or some chemicals, the soreness is more prominent than the discharge. The soreness is more prominent than the discharge. We have found one patient that uses some chemicals as contraceptives, sponge today. The patient comes to us with abnormal vaginal discharge and due to some irritation, maybe the irritation is there, and with the withdrawal of that chemicals, the vaginal discharge subsides. So chemical reactions, the soreness is most prominent than the discharge. The chemical are one of the important causes. We should keep it in our mind when we investigate a case of the abnormal vaginal discharge. And if the discharge is offensive with pruritus, condition may form contamination from stool or urine. And in cases of the neoplasia, the CA cervix or CI stage 0 carcinoma, cervical intraepithelial neoplasia, the discharge is usually serosanguineous. Now inquire about the contraceptive practice. If the patient has a history of the prolonged use of the estrogen-progesterone combination pill, the patient may have the abnormal vaginal discharge due to affections of the Candida albicans. The patient uses latex or latex condom and may have the allergy to the condom and which produces vaginal discharge. Chemicals and use of the IUCD are to be elicited. Drug history is to be taken as we have discussed before, the use of the antibiotics and steroids. Prolonged use of the antibiotics and long use of the steroid may produces the Candida albicans affections or the moniliasis. Again, medical history: prolonged suffering from the diabetes mellitus, maltreated diabetes mellitus produces candidiasis or the moniliasis and produces excessive vaginal discharge, abnormal excessive vaginal discharge. And inquire about sexual behavior, sexual STDs, HIV, and psychosexual factors all are to be inquired during case taking. And if there is any episodes of the leukorrhea or abnormal vaginal discharge, then this should be elicited properly. Now we comes to the physical examination. How to do the physical examination of the patient? First of all, the general examination. In the general examination, the patient have inquire about the poor health and anemia. So poor health and anemia is one of the important causes of the disease, the cause of the abdominal vaginal discharge in our countries. Nutritional status, poor nutrition, temperature. Abdominal examination. Abdominal examination is done when we suspect there is upper genital tract infection, and abdominal palpation for tenderness and any mass is present or not. Valval inspection is to be carried out for discharge, redness, inflammation, ulcer, scratch mark, and smell. And if there is genital ulcer, that also to be noted down. Now important speculum examination. Speculum examination is done to find out any pathology. So vaginal examination with the help of vagina, what we see in vagina, what are the changes which may be present in the vagina in patients presented with the leukorrhea. These are the edema, erythema, petechial spots, ulceration, and discharge. So ulceration and discharge. Cervix, presence of cervical erosion or cervical ectopy. And another thing, this petechial spot in the upper vagina and the cervix, in cases of the trichomonas vaginalis affections, this gives the appearances of the cervix strawberry. So strawberry vagina and strawberry cervix is the characteristic findings of the trichomonas vaginalis affections. The next point is ectropion, cervical erosion, ectropion, eversion of the cervix, whether in cervix there is ulcer, polyp, and or any other growth, and whether there is a mucopurulent discharge, which is indicating that the patient may have chronic cervicitis. Now the bimanual pelvic examination is done for tenderness, adnexal tenderness, or uterine tenderness, and cervical motion tenderness, whether anything abnormal in present in the cervix, or the patient may have the PID, pelvic inflammatory disease. This is another cause of the vaginal discharge, and pelvic mass and foreign body, presence of any foreign bodies or not. Foreign bodies means in uterus there may be for IUCD may be there, which may causes the cervical abnormal vaginal discharge. Now investigations. How we proceed for the next step, the investigations. Investigation. Pap smear. Pap smear for cervical cytology. Pap smear for cervical cytology is to be done. Pap smear for cervical cytology is to be done in all the cases suffering from the abnormal vaginal discharge residing in unhygienic condition residing in rural area. Pap smear means because we know the HPV virus is one of the important causes of the cervical carcinoma. So pap smear, finding of the atypical cells in pap smear does not means the patient is immediately will develop the CS cervix. That means the patient may have the potentiality to develop CS cervix in later life. So here we have to treat the patient to correct the abnormalities. Modern medicine has different view. I am not going to that. So this pap smear reduces the incidence of the cervical carcinoma a lot. Next, high vaginal swab for from posterior vaginal fornix, and this high vaginal swab is subjected for gram staining or diagnosis of Candida albicans, bacterial vaginosis, and Trichomonas vaginalis. And this swab, high vaginal swab, we also help to diagnose the Neisseria gonorrhoeae and Chlamydia trachomatis also. Next investigations, the wet mount microscopy of the discharge. This investigation is not very difficult to perform. Simple, collect the sample from the posterior fornix, the vaginal sample of vaginal discharge from the posterior fornix, and make slide and see under microscope. Then prepare the slide with normal saline. Under the microscope, we can see the pear-shaped motile organism, flagellated motile parasites, that is Trichomonas vaginalis. That is Trichomonas vaginalis. And in cases of bacterial vaginosis, the characteristic features is presence of clue cells. What are the clue cells? Clue cells are nothing but the vaginal epithelial cell. When we prepare the slide, we disperse the vaginal epithelial cell, and this vaginal cells are covered in places covered with that coccobacilli, and it gives like the stipple form, and this stipple form cells are called clue cells, and these are present. These are the characteristic cells of the bacterial vaginosis. And for the diagnosis of the Candida albicans, same thing. Instead of normal saline, prepare the slide with the help of potassium hydroxide solution, 10% KOH solution. Under the microscope, we can see the fungus, seen the hyphae and the mycelia. Next, whip test or amine test. This is not actually done regularly in all and every cases, but a whip test is done in cases of the suspected bacterial vaginosis. Simple test. The specimen is taken, added some KOH, and there is characteristic fishy odor emits. This is whip test, amine test. This is positive in cases of the affections with bacterial vaginosis. Now another important thing, that is the vaginal pH. The help of the pH paper. It is again usually not done in our clinic routinely, but we should know, being the person of the scientific society, we should know the Candida albicans prefers the vaginal pH 4.5. Bacterial vaginosis and trichomoniasis prefers 5 to 6, and in cases of the atrophic vaginosis, more towards alkaline, that when the pH is 6. Next, endocervical swab. Cervical swab was there for the diagnosis of the cervicitis and vaginitis, that affections with the Trichomonas vaginalis or Candida albicans. But the endocervix is the potent reservoir of gonococcus and the Chlamydia trachomatis. For diagnosis of the gonococcus and Chlamydia trachomatis, it is better to collect swab from the endocervix, and this swab is subjected for gram staining for diagnosis of gonococcus. And then another investigation is there, that is nucleic acid amplification test. This test is done for diagnosis of the several viruses and bacteria mainly, and the bacteria also. Here, in cases of the abdominal vaginal discharge, this is performed for the identification of the genetic sequence, the DNA sequence of the gonorrhea and the Chlamydia trachomatis mainly. And if further investigation, if we required, then we may do the culture thiomertin media for gonococcus, and the culture for the Trichomonas and Candida is not done. Is usually not done because it is not very easy. The media is not commonly used, and it is usually done when the microscope is inconclusive, because with the help of the microscopy, the diagnosis can be performed. Simple, under microscopy, we can see the Trichomonas vaginalis and Candida albicans affections. Next, if there is presence of dysuria and other urinary symptoms are present, then urethral swab for diagnosis of the chlamydia trachomatis and for the diagnosis of the UTI associated UTI midstream urine collection culture sensitivity test may be done. And then HIV serology, nowadays it is performed as a routine, and blood test when the diabetes mellitus is suspected in susceptible patients, and stool investigation of the stool. This is also very important. REME and occult blood test, but in a presence of the ova, Trichuria trichuris. This is very important because Trichuria trichuris affection is one of the important causes of the irritation that produces abnormal vaginal discharge. Particularly in the patients of lower socioeconomical conditions, the belongs to the lower society, then this test, stool test, is often helpful to diagnose the warm affections. Now this I think in brief I have attempted to put the view, describe the modern medicine, the allied part of the abnormal vaginal discharge. Now we will enter into the homeopathic part. Now you will enter into the homeopathic part. So homeopathic part of abnormal vaginal discharge. So homeopathic part, in the homeopathic part, the first of all miasmatic analysis, miasmatic background of the abnormal vaginal discharge and the leukorrhea. So what is the characteristic features of the psoric leukorrhea? If the patient has the psoric background, the leukorrhea is scanty, not exhausting, and nothing peculiar about color. So all the normal excessive vaginal discharge. So all the normal excessive vaginal discharge comes to under this heading. So psora. What happened with pseudosora? If there is pseudosora background, the leukorrhea usually purulent, but maybe watery mucus, and it may be deep, thick, yellow, or yellow is green also, and sometimes lumpy, thick, albuminous, or purulent, and smelling musty in pseudosora background also. Syphilis seldom attacks the ovaries and the uterus. Syphilis seldom attacks the ovaries or the uterus. And what happened with the psychosis? The most frequent location of the psychotic manifestation in women is the pelvic organs. So pelvic organ, uterine affections and the ovarian affection, if there is usually in most of the cases, not all, in the most of the cases, the patient must have the psychotic background. So the most frequent location of the psychotic manifestation in women is the pelvic organs. Pelvic inflammations such as inflammation of the ovaries, inflammatory process affecting the fallopian tubes, all inflammatory discharges from the female pelvis may be tracked under the heading of the psychosis. So psychosis is very important for the abnormal vaginal discharge point of view. So leukorrhea, what is the characteristic of the leukorrhea? Of the psychosis, we find that most of the infective leukorrhea comes under this heading. The leukorrhea is thin, looks like dirty green water, sometimes greenish yellow, scanty, acrid, producing biting and itching or burning of the parts. Odor of the stale fish or fish brain, this is characteristic, and the discharge may be pungent or like the decayed fish. Patient forever taking douches on account of the odor is so offensive and acridity of the discharge. Often this produces little vesicles or excoriations of the pudendum, which are a source of great annoyance to the patient. This comes under the psychotic leukorrhea. H. Roberts, I have quoted one portion from the H. Roberts. The fish brain odor is characteristic of all psychotic taint. So fish brain odor, which is present in the bacterial vaginosis. and to some extent the fish-brain order also present in trichomonas affections, and it may appear in all discharge, but especially in the discharge of the genital tract. Psychotic discharges like tubercular are greenish or greenish yellow. This quotation is from H.O.D. Roberts. This are in brief about the miasmatic background. Now, when we discussed about leukorrhea and when we discuss about the treatment part, apart from all theoretical aspects, being the homeopathic physician, we should know the drugs which includes the symptomatology of the abnormal vaginal discharge. Again, before going to the therapeutic part, one thing I would like to share one opinion. This is my opinion that leukorrheal discharge, it may be characteristic, it may be striking, singular, uncommon, peculiar characteristic, but it not more forms the totality, not all. It may be an important part of the totality of the symptoms. So whenever we treat a patient with leukorrhea, so leukorrhea is not the disease, it is a symptom of the so much conditions. So much etiologies are there, infective cause, irritation cause, etc., etc. Some surgical conditions, some medical conditions are there. But whenever we do treatment, if the character of the leukorrhea or the vaginal discharge is uncommon, peculiar, striking, singular, like the as mentioned in the 153. So this aphorism 153, this forms an important part of the totality and often helpful for the selection of a simillimum. Being the homeopathic physician, first of all, we would like to share some name of the some medicines which are comes with indications which are often used by the homeopathic physicians in their clinics regularly. Yeah. So before going to that part, now general management, this is very important. What should be our plan of action to treat the patient suffering from abnormal vaginal discharge? So first of all, classify the disease, identify the disease, whether it is acute condition or whether it is a chronic manifestations. Then second point relates to aphorism 7, the removal of the maintaining cause. What is written in the aphorism 7? Now as in disease from which no manifest exciting or maintaining cause is to be removed, we can perceive nothing but the morbid signs and symptoms. That means when there is the maintaining causes or manifest exciting and maintaining causes are there, if we blindly prescribe medicine, that this will not work. First of all, like if there is chronic irritation, some remove that things. If the patient's problem is due to use of the oral contraceptive pills, prolonged use of the antibiotics or some medication, some irritation, some trichuritis affection, then we should have to remove that things. We should have to remove the causes, manifest exciting or maintaining causes which are producing the excessive vaginal discharge. Then after removal, then we comes to the totality of the symptom, construction of the totality of the symptom. This is the most important part. As I told before, the leukorrheal discharge are often proved an important part of the totality of the symptoms. The more striking, singular, uncommon, peculiar characteristic signs and symptoms of the case of the disease are chiefly and most solely to be kept in view. Master Hahnemann told this in aphorism 153. So this striking, uncommon, peculiar features, sometimes the vaginal discharges have those characteristics, and this often helps to point out which of the homeopathic medicine is the simillimum of that case. Then selection of, after construction of the totality, we have to do the selection of the medicines. Along with this, the accessory measurement, the improvement of the general health, correction or maintenance of the diet and regimen. If the pill users may have to stop pill temporarily if the symptoms are very much annoying, then treatment for the specific infection with appropriate medications selected on the basis of totality of the symptoms. Now comes to that part, the therapeutic part. I am quoting a few homeopathic medicines which are used by the homeopathic physicians regularly for the treatment of the abnormal vaginal discharge of the leukorrhea. First of all, we should mention from our experience in the hospital or the clinic, the first medicine we would mention the name of the sepia. Sepia is one of the clinically reputed medicine for the treatment of the abnormal vaginal discharge. Sepia is polycrest medicine. It covers all the miasm, psora, syphilis, and psychosis. Strongly psychosis. It covers psychosis. Now, the character of the discharge of sepia is yellowish, thick leukorrhea, acrid leukorrhea with pain when walking, acrid leukorrhea with soreness of the pudendum before the menses. Sepia is good medicine for mucus leukorrhea also, with the discharge of fetid mucus flux. If we correlate with this with the Candida albicans modern medicine, we find this type of the discharge occurs in cases of the Candida albicans affections. Leukorrhea of yellowish or greenish water or of bad smelling fluid like pus. If we relate these things, medical knowledge to the allied knowledge, this type of the discharge we find in cases of the infection with Trichomonas vaginalis. Yellowish discharge in the morning with peering down in the pelvic organ. Next, sepia is good medicine for milky vaginal discharge flowing only in the daytime. This is medicine for the daytime leukorrhea with burning pain and excoriation in the thigh. Sepia also covers the yellow or green purulent offensive discharge causing itching to the genitalia, labia are sore and swollen, stitches in the vagina. CPA is good medicine for profuse discharge after urination or making an effort to vomit. Whenever the patient goes to vomit, there is a vaginal discharge. This is a characteristic symptoms. And this type of the discharge often relieved by the sepia. I have treated few cases with vomiting and relief. Few cases, not many, too many. Now, leukorrhea during climacteric period or during pregnancy. Medicine is sepia. Good medicine. It is a clinically reputed medicine for treatment of the such type of the discharges. Now, next we goes to the number 2 and number 3. These are often used in the homeopathic clinics by the homeopathic physicians. Number 1 is the Bovista and number 2 Borax. The discharge, characteristic discharge of Bovista is like albuminous, thick, viscid, albuminous discharge, like white of an egg, especially when walking, dropping out in a coagulated mass or clot. Patient comes to you, tell that whenever I play, whenever I go to the cycling, then after that there is discharge of a mass, white discharge, in clotted discharge is there. Leukorrhea with yellow green color, acrid, corrosive, leaving green stains upon the clothes. And what is the characteristics discharge of the Bovista? Similar characteristic discharge, white albuminous discharge like white of an egg, like Bovista, and like starch. But here there is what is the peculiarity of the Bovista? What is the characteristic features of the Borax? The Borax has the sensation as if warm water were escaping and fear of downward motion. Leukorrhea midway between menstrual period. So leukorrhea oats between period. Leukorrhea oats between period. Here we have 3 medicine: Bovista, Borax, and creosote. Acrid, corrosive, offensive leukorrhea oats between period. In between 2 menstrual cycle, leukorrhea is there. Bovista, Borax, creosote. Here in this slide, we find these 3 medicines. Next, sterility on account of the chronic acrid leukorrhea, thick, corrosive, burning leukorrhea. The Borax is medicine. Borax is a very good medicine. Please apply this in that cases where there is warm water escaping sensation along with the sterility due to the acrid leukorrhea. Borax is very good medicine. Next, creosotum. Creosotum is important medicine and popular medicine for the acrid. It is popular for its acridity and offensiveness. The discharge of the creosotum is acrid. Usually, it is acrid, leaving yellow spot on the linen. The discharge also stiffens the linen like starch. And what is the uncommon, peculiar, singular, striking symptoms of the creosotum? That is the smelling like green corn. The discharge, abnormal vaginal discharge of the creosotum is smelling like the green corn. If we correlate with these symptoms with the knowledge of the modern medicine in the symptomatology of the no infection or other things, or no causes of the leukorrhea, we find this where the smelling of the green corn occurs. So this is it. This symptoms cannot be explained with the knowledge of our modern medicine. So this is a very important symptom for the selection of the homeopathic medicine. The medicine which cannot be explained by the knowledge of the modern medicine is very important for the selection of the homeopathic medicine. Now, creosotum, under the symptomatology of the creosotum, we find leukorrhea inclined to be intermittent. Sometimes the patient discharge diminishes and the patient thinks that she is almost cured from the leukorrhea. He thinks that leukorrhea is cured, but when she is thinking that leukorrhea is almost cured, and without any apparent cause, it reappears. And it reappears, not only reappears, it becomes aggravated as ever. Now, acrid corrosive offensive course between period and acrid yellowish leukorrhea with great itching of the vulva. Creosotum can be used for mild and painless as well as you treat acrid corroding leukorrhea also. Next medicine, which without mentioning this alumina, the discussion with the abnormal vaginal discharge cannot be completed. The leukorrhea cannot be completed. Leukorrhea is acrid and profuse, running down to the hills. This symptomatology also we find under the drug syphilinum. Abundant discharge of transparent mucus flowing only in the daytime. Again, sepia and alumina in daytime. Sepia and alumina is in the daytime. And attended with great weakness and a sensation as if everything would fall through the vagina. Profuse yellow corroding discharge hours before and after menstruation. Alumina leukorrhea, maybe watery leukorrhea is there, but leukorrhea sometimes become like the cream and painless leukorrhea. Chronic leukorrhea, clear like water, or a transparent mucus stiffens the leiden and relieved by cold bathing or cold washes and aggravated by walking and during daytime. Now this I have pointed out few medicine, five medicine, I think five medicine for our five or six medicine which are clinically reputed medicine. Now for the discussion purpose, I have collected some characteristic symptoms related with leukorrhea. These are some characteristic symptoms of the drugs these symptoms are often helpful for individualizing the patient as well as the drugs. These symptoms are related with leukorrhea. What are these? Under Ammon curve, drug Ammon curve, we find leukorrhea burning from the uterus, acrid, profuse from the vagina and excoriating the vulva. Another good medicine is for the abnormal vaginal discharge is Calophyllum. Calophyllum is have many female symptoms in its symptomatology. Calophyllum is very good medicine for leukorrhea when the leukorrhea is acrid excoriating. Along with this acrid excoriating leukorrhea, the associated symptoms is there is heaviness of the upper eyelid, has to raise with the fingers. This also presents on the symptomatology of the Calophyllum gelsemium. With the moth spot over forehead, leukorrhea with moth spot over forehead, we find sepia and Calophyllum. Leukorrhea in little girl leukorrhea, the Calcutta is the medicine. Along with Calcutta, another reputed medicine is Calophyllum. And leukorrhea preventing pregnancy is Calophyllum. So Calophyllum is another good medicine, another clinically reported medicine for abnormal vaginal discharge. Under the iodum, where there is cancerous background, where there is suspected CS cervix or cancerous degeneration of the cervix, and the patient having abnormal vaginal discharge, acrid, corrosive, staining and corroding the linen, most abundant at the time of the menses. The medicine, indicated medicine is iodine. This symptoms is present under the symptomatology of the iodine. Now, another thing, leukorrhea with great debility. Leukorrhea with great weakness. Weakness seems to proceed from the chest. If this with this leukorrhea plus debility plus weakness proceeded from the chest, medicine is sternum. Leukorrhea plus great debility plus weakness seems to proceed from the abdomen or pelvis is phosphorus and sepia. Next, color of the leukorrhea. Bluish leukorrhea, amblyopia, thick bluish white mucus, and specially and only at night. We find the daytime leukorrhea we find under sepia, under alumina. Now the leukorrhea at night, amblyopia, causticum, mercurius, nitric acid. These have the leukorrhea only at night. Bluish white mucus, specially and only at night. 4 medicines are there. Amblyopia for important medicine. In repertory, there may be another more medicines are there, but 4 important clinically reported medicines that are amblyopia, causticum, mercurius, nitric acid. Under symptomatology of acnus custus, we find transparent but staining linen yellow passes imperceptibly from the very relaxed part. Under the drug sickle core, the characteristics of the leukorrhea is green-brown offensive. Green-brown offensive, like the leukorrhea that caused by the Trichomonas vaginalis, etc. Green-brown offensive. Under acid nitricum, the characteristic vaginal discharge is brown, flesh-colored, watery, and stringy, and offensive also. Now, aurum mur. Aurum mur, the discharge, character of the discharge is like white of an egg, preceded by gripping pain about the navel. Pain abdomen with abdominal vaginal pain, abdominal vaginal discharge, white like the egg. Sometimes the discharge may be brown, slimy, painless after every urination. That is the under symptomatology of ammon mur. Now, leukorrhea 10 days after menses. That means in between menses, 10 days after menses, borax, bovista, conium. Leukorrhea acrid, bloody, milky, profuse, thick, and intermits, conium maculatum. Leukorrhea aggravated after exercise with every stool, with uterine spasm followed by metrorrhagia 2 weeks after menses for 3 or 4 days. The medicines are macmur, borax, bovista, and conium. Leukorrhea in places of the menses. Instead of the menses, abnormal vaginal discharge occurs under the drug Nux moscata and conium. Leukorrhea in places of the menses or between the periods, cocculus, iodum, xanthocyanum. Leukorrhea like washing of the meat, like serum, echorious blood. During pregnancy, leukorrhea is cocculus, particularly in bookworm ladies. Now, under the graphitis, we find acrid excoriating occurs in gases day and night, before and after menses. That is graphitis. Before and after menses, abdominal vaginal discharge is medicine graphitis. Before menses, sepia, and after menses, creosote. This is a common clinical practice. Clinical practice is the before and after menses graphitis, before menses sepia, and after menses creosote. Now the discharge has strong odor of fish brain. We find under sanicula. Sorinum. Sorinum is another polycrest medicine. Here the vaginal discharge is large clotted lumps of an intolerable odor, violent pain in the sacrum, debility during climaxes. Under mercurius, leukorrhea acrid, burning, itching with rawness, always worse at night. Under Thalapsi bursa pastoris, this is one medicine for metrorrhagia, menorrhagia, C. cervix, C. uterus. That in that case the discharge is bloody, dark, offensive, some days before and after menses. In children, after atony, before we find the leukorrhea in children, this is Calcutta cob and colophyllum, and leukorrhea of children from atony, melifolium and Calcutta curve. In this regard, another thing I would like to share with my from my experience, that the patients, the children suffering from the vaginal discharge, on examination, on history taking, we find that the patient is suffering from the trichuria. Simple warm remedy, remove the warm irritation, that the maintaining cause for the abnormal vaginal discharge. So simple warm medicine, warm removed, warm relieved, and the discharge is also relieved. ঠিক আছে, this is this one thing from my experience. Now menstruation, leukorrhea, diarrhea, all are exhausting under carboanimelis arsenicum sorinum. The characteristic discharge of the murex is very uncommon, peculiar, striking. The leukorrhea worse during mental depression, happier when the leukorrhea is worse. Leukorrhea is worse, the patient is happier. Now, this is probably the last slide. The Hydrastris is another good medicine for the abnormal vaginal discharge. Hydrastris along with calibicromicum. Both are separate medicine, but the symptoms, these symptoms presence under hydrastris and the symptomatology of calibicromicum. The rope where the discharge is ropey, thick, viscid, yellow, hanging from the os in long string along with pruritus. Under pulsatilla, the leukorrhea is creamy, associated with burning, and the discharge is acrid. Under palladium, the characteristic of discharge is glary discharge. And another important medicine which is often used by the homeopathic physician practicing in the rural area, the electrospherinosa. The electrospherinosa leukorrhea is due to weakness and anemia. Those patients are suffering from malnutrition, anemia, residing in the low socioeconomical condition, residing in the rural area, and suffering and emaciated. In that cases, the electrospherinosa often relieve these symptoms. So leukorrhea due to weakness and anemia. This is very important symptoms, particularly for those physicians who are practicing in rural areas. Next, the vaginal discharge with lameness of the back across the sacroiliac articulation. The discharge is dark, yellow, sticky, corroding, or after menses, the asculus hypocastrinum. This medicine is rarely uses the vaginal discharge with backache. Now, thank you for with me for this discussion and allow me to share my knowledge with leukorrhea. Thank you. Here I am concluding.
Thank you so much, sir, for such a informative presentation. Now, I would like to request Professor Dr. Rajat Chattopadhyay, sir, to give his valuable opinion regarding this topic. Sir.
First of all, I must congratulate Dr. Debashis Biswas, H.O.D of Gynecology and Obstetrics Department of the Calcutta Homeopathic Medical College and Hospital, and a nicely elaborative study on leukorrhea and discharge related to that. It was wonderful presentation, and I must congratulate again, just to make it with not only confined to gynecology and obstetrics subject, also to make it homeopathic with homeopathic orientation from organ and point of view to mathematica based. It is good one. Now, this is my topic. It is based on arthritis. Arthritis, it is not a very common term that or very single term that arthritis can be told within a span of 1 or 2 hours. It's a very vast subject. Even one only osteoarthritis or rheumatoid arthritis, any one can be the topic. But what I want to emphasize here, just brief about the outline of the arthritis with the latest and with the updates, what is going on. A little bit of discussion with the detailed concept of arthritis. I want to share my screen first. Is it okay?
Yes, sir.
Okay, so arthritis, a detailed discussion with its updates and homeopathic approach. So first of all, we must go through degenerative and crystal-induced arthritis, and it is osteoarthritis. The slides are changing now. It is visible to all. I hope that every slides are visible. The slides of osteoarthritis is visible to all. Pratima?
Yes, sir. It is visible.
Okay. So what is osteoarthritis? A degenerative disorder with minimal articular inflammation. Emerging evidence has identified genetic mutations that confer a high risk of osteoarthritis. The best replicated is a polymorphism within the growth differentiation factor 5, that is GDF5 gene. So not only it is that a degenerative disorder and it is very common with the age, or it is very common with the weight bearing organs, or it is related to obesity. Definitely it is related to obesity, definitely it is related to age, but just consider the genetic predisposition also, and polymorphism within the growth differentiation factor GDF5 gene. So no systemic symptoms. If we compare with the rheumatoid arthritis, where or rheumatic arthritis, where the manifestation is very much systematic, here systematic symptoms almost nil. Pain relieved by rest. Morning stiffness brief. Morning stiffness is the characteristic of rheumatoid arthritis. Morning stiffness is the characteristic of rheumatoid arthritis, but I must say that little type of stiffness also present in osteoarthritis. But if you compare with rheumatoid arthritis, it is much more in rheumatoid arthritis, and it is more than 30 minutes. So it is pain relieved by rest. Radiographic findings, very common, that is a narrowed joint space, osteophytes, increased density of subchondral bone, bony cysts. In all osteoarthritic cases, you can find this one. It may be of knee, it may be of hip, it may be of your even of cervical and lumbar vertebra. Now, gouty arthritis. Gouty arthritis, acute monoarticular arthritis, often of the first metatarsophalangeal joint, and recurrence is common. Recurrence is very much common. Polyarticular involvement, more common in patients.
Sir,
Hello, hello,
sir, sorry to disturb you. Can you
yeah,
please play the slides? Slides are not changing.
okay. Which one is showing?
The
Only
first slide.
osteoarthritis.
First slide.
Which first slide? Osteoarthritis or which one?
Arthritis, a detailed discussion with its updates.
Sorry, sorry. Hello,
Yes, sir.
hello, hello. Okay, I am again sharing my screen. Okay.
Okay, 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 sir.
Now it is visible. Is it visible?
Yes, yes, sir. Please
Okay.
change.
Now I am changing. It is visible.
Yes, sir. Yes, sir. Yes, sir. Now it is changing. Okay.
Okay. So I have gone through the osteoarthritis, a degenerative disorder with minimal articular inflammation and emerging evidence has identified genetic mutations. I already told, so which is important. That is the GDF5 gene. It is very important. The polymorphism within the growth differentiation factor. No systemic symptoms in comparison to other rheumatoid arthritis or any other gout rheumatic arthritis. In osteoarthritis, no systemic symptoms usually. Pain relieved by rest, morning stiffness brief. I am telling that morning stiffness is the characteristic of rheumatoid arthritis, but in osteoarthritis, it may be very brief. It is not like 30 minutes of morning stiffness like rheumatoid. Radiographic findings, narrowed joint space, osteophytes, increased density of subchondral bone, bony cysts. Gouty arthritis. It is unilateral involvement, monoarticular arthritis, often in the first MTP joint, we know the podagra. Recurrence is very common in any gouty arthritis. Polyarticular involvement more common in patients with long-standing diseases. If this gout become the chronic gout, and in that case, you cannot say that it will be only unilateral. In that case, polyarticular involvement is very common. Identification of urate crystals in joint fluid or toffee in case of chronic tophi is very diagnostic. The painless crystal accumulation. And dramatic therapeutic response to NSAID. You know NSAID, non-steroidal anti-inflammatory drugs. Whenever from modern medicine it was given, the dramatic therapeutic response, the pain disappear. So it is very much to diagnose it. If you ask the patient whether you have taken any painkillers or like NSAID and the pain whether disappear or not, and it is unilateral and night aggravation, so you can easily diagnose it's a case of gouty arthritis. With chronicity, urate deposits in subcutaneous tissues, bones, cartilage, joints, and other tissues, even in the lumbar regions, even in all other cartilage, joints, etc. Even the kidney functions may hamper, even the renal stones by the deposition, but only if it is becoming a chronic one. Now, the musculoskeletal manifestation of crystal-induced arthritis. These may be acute mono or polyarthritis, tendinitis, destructive arthropathies. It's a very important one that the very several destruction may occur in the joint, like the podagra, the first metatarsal phalangeal joint. It's a very destructive type of arthropathies you can be seen. Spinal arthritis. It is also common to crystal-induced arthritis. So don't think that it is only confined to your podagra like or only great toe. It will be it may be a spinal arthritis, carpal tunnel syndrome like syndrome, chronic inflammatory arthritis, and tophaceous deposits. These are the all musculoskeletal manifestations of crystal-induced arthritis. So whenever there will be hyperuricemia, whenever there will be crystal-induced arthritis, you think of all these. Whenever you will be differentiating the disease, that what disease the patient has been suffering from, it is not only only single gout, not only single spondylosis, not only single osteoarthritis or rheumatoid arthritis. You will be thinking of all these, that the patient's having hyperuricemia, the patient having the crystal induced chronic type of disease. So these type of arthritis related manifestations may be there. So these are very common. That's why this slides is here. So don't forget the tendinitis. Don't forget the spinal arthritis. Don't forget even the carpal tunnel syndrome and chronic inflammatory arthritis. Now let us talk about autoimmune disease, because we have to brief all about the arthritis and the the autoimmune disease, the autoimmune arthritis are very common nowadays. Even the rheumatoid arthritis is the very commonest one among all the autoimmune mediated arthritis. But I have to go fast because we have to cover all the arthritis related disease. And if you have any query or questions, then it may be in the afterwards in the chat box. So rheumatoid arthritis usually insidious onset with morning stiffness and joint pain. So morning stiffness, don't take it very casual one, because morning stiffness, if it is going on regularly and with 30 minutes time of morning stiffness, it is the first precursor of the rheumatoid arthritis may be there, and the joint pain. And symmetrical polyarthritis, in comparison to all other arthritis, osteoarthritis or gouty arthritis or other rheumatic arthritis. The symmetrical polyarthritis is very, very common to this rheumatoid arthritis, and I must say it is not only rheumatoid arthritis, it may be some other autoimmunity mediated arthritis, it can be also seen. But in common, we must say that symmetrical polyarthritis is the characteristic of rheumatoid arthritis, with predilection for small joints of the hand and feet, and deformity is common with progressive disease. So deformity is one of the most characteristic. Radiological findings: juxta-articular osteoporosis, joint erosions, joint space narrowing. Rheumatoid factor and antibodies to cyclic citrulated peptides, that is anti-CCP, are present in 70 to 80% cases. Extra-articular manifestations, these are very important, like subcutaneous nodules, like interstitial lung disease, like pericarditis, splenomegaly, vasculitis. So it is very common that patient may appear with these extra-articular manifestations, but the most commonly joint symptoms may be in very minimal. So you can't, you may be in fix that what is the diagnosis. So you should know that the subcutaneous nodules, not only the subcutaneous nodules, the interstitial lung disease even is connected with autoimmunity mediated arthritis like rheumatoid arthritis, even the pericarditis, splenomegaly, or vasculitis also. So these are the symptoms. All the, you know, the criterias, the rheumatoid arthritis, and you can see the deformities, the swan neck deformity, boutonniere deformity. These are the characteristic deformity, and these all are the, from the morning stiffness to disability to the deformity. These are the characteristic of rheumatoid arthritis. Now the updates. Is rheumatoid arthritis is a two different diseases? We know that most of the patient having all the symptoms of rheumatoid arthritis, and even we have diagnosed it clinically that it is a case of rheumatoid arthritis, but they remain totally, their investigations from the pathological point of view, zero, no positivity. So all these are called seronegative rheumatoid arthritis. So it is found that while disease activity improves over time for most RA patients, long-term outcomes only improve in RA patients with autoantibodies. The patients having RA positive or autoantibodies positive, all those patients recovered, or all those patients response to the treatment much more in comparison to repeatedly. It has gone through 3 research studies, and in the last research study published just 2021 in July, just 4 days back, and the previous 2 studies, the last third studies, it is said that the previous 2 studies were right. Probably we have to go through within coming 2 to 3 years with the separate entity of seronegative rheumatoid arthritis and seropositive rheumatoid arthritis, because it is not the same. We very often casually we say that the patient having RA factor negative is seronegative and all other seropositive, but it has been observed repeatedly that the patient having autoantibodies positive, they are giving response to treatment just specific for rheumatoid arthritis, and all others they are not giving response which is specific for rheumatoid arthritis. So these two diseases may be a different entity which is now a subject of research. An update on research advance in rheumatoid arthritis from clinic to basic science. One paper, wonderful paper, is that this review provides a summary of the main recent research advances regarding new therapies in rheumatoid arthritis and new studies about the effect of genetic, environmental, and epigenetics in these autoimmune disease. These research studies reveal, this is not only one research study, and these all the studies we have been taken from very reputed journals with peer reviews journals, index journals, and nature like journals. So these are the research studies in which it is found that these type of rheumatoid arthritis like autoimmune disorders, they depend in the predisposing factors, the epigenetics, the environmental factors, the genetic factors are the mostly responsible in cases. And so for the treatment of this, you have to consider all this. So moreover, it summarizes the present knowledge about the role of new autoantibodies in RA, focusing on, this is one new autoantibody, anti-carbamylated protein antibodies, that is anti-CARP. It is not anti-CCP. It is not anti-CCP, the new one. It is anti-CARP. Again, anti-hinge antibodies. Again, anti-acetylated protein antibodies and anti-malonyl dehydrate acetylide adducts, that is MAAA antibody. So these are the all new auto antibodies found in RA. It will be coming. Already it is here, but the concept of these in the formation of rheumatoid arthritis, the environmental epigenetics and genetics, again the consideration of it during this treatment and management, and consideration of new and newer auto antibodies, whether the research is also going on, whether these auto antibodies, these markers have got any effect in the formation of rheumatoid arthritis. It is also a concern. It is also a question of concern. So we have identified the markers, we have identified the auto immune bodies, but whether these are responsible for the formations of these are also a challenging attitude. So we have to, these are the new research papers. Now another one, adult Still's disease. It is a systemic form of juvenile chronic arthritis. I must repeat, it is a form of juvenile chronic arthritis in which spiking fever more prominent than arthritis. So if we consider adult Still's disease, before arthritis, we must think of spiking fever. You know, spiking fever, whenever you tell spiking fever, we think of UTI, like, or any intermittent fever, like, or any viral disease like spiky fever. But spiky fever is also characteristic of adult Still's disease. We know that Still's disease is very common to children, which is one of the variant of rheumatoid arthritis, very much differentially diagnosed. It is differentially a diagnostic part of the Still's disease. You know, the variant of the rheumatoid arthritis, the Feltis syndrome, etc., etc. But the adult Still's disease with the spiking fever, with the salmon colored non-pruritic rash. It is not that pruritic rash, it is non-pruritic rash, and chiefly on chest and abdomen, it is a characteristic feature. So with the spiking fever, with the salmon colored rash in the chest and abdomen, and with the juvenile form of arthritis but found in adult, is our adult Still's disease. How will we diagnose it? They diagnose it by the quotidian fever pattern, the sore throat, the classical rash on chest and abdomen with salmon colored, and exclusion by the process of exclusion of cause of fever. We have to exclude the other cause. Then the remaining cause may be our adult Still's disease. Now the another one. Systematic lupus erythematosus, SLE, occurs mainly in young women. Why I am mentioning this? Because arthralgia and arthritis-like symptoms are very much common in SLE. Joint symptoms, you just see it in red. Joint symptoms in 90% of patients. 90% of patients of SLE, joint symptoms are there, and arthritis can lead to reversible swan neck deformities, but erosive changes are almost never noted on radiographs. So which is the erosive changes or the destructive changes are very common to gouty arthritis or any deposited urate deposited arthritis, which is not common that erosive changes in SLE. So reversible swan neck deformities you can find in SLE. So if you treatment our homeopathic constitutional treatment, if the patient is not in very bad position, it is reversible. Even the swan neck deformities, it is written in the book that it may be reversible. So we must think positive whenever we will treat SLE patient. It is not that SLE is very bad one, we should refer it and there is no treatment like that. No. You should go through the clinical medicine. A rash over area exposed to sunlight. We know the photosensitivity of the SLE, the anemia, leukopenia, thrombocytopenia. These are the classical triad. You can find all the three in SLE. There will be anemia, there will be leukopenia, there will be thrombocytopenia. So these triad are very much important in case of SLE. With the SLE, glomerulonephritis, the CNS disease, and complications of anti-phospholipid antibodies are major source of disease morbidity. So itself, disease morbidity is not much more in SLE, but whenever it is complicated with glomerulonephritis, chronic kidney disease, or any CNS disease, or even anti-phospholipid antibodies like autoantibodies are there, so the cause of morbidity may be there. Those may be the source of morbidity in case of SLE. Serological findings, always ANA, anti-nuclear antibodies, 100% specific, anti-double standard antibodies, approximately 2/3. Low serum complement levels, particularly during disease flares. These are diagnostic criteria. Now, relapsing polychondritis. It is characterized by inflammatory destructive lesions of cartilaginous structure. What are the cartilaginous structures? Ear, nose, trachea, larynx. These are characterized by inflammatory destructive lesion. In 85% cases, it is migratory, asymmetric, it is not symmetric, asymmetric, seronegative arthropathy occurs affecting both large and small joints. So it is the combination of our rheumatoid arthritis and other arthritis. So it is affecting both large and small joints. It is migratory type. It is not symmetrical. It is asymmetrical. It is seronegative arthropathy. Very so the neonates, all the new practitioners, they will be in a fix. What to do? Because they can't diagnose it because seronegative arthropathy is there. So with a very good clinical acumen, the or weapon you have, with the knowledge of clinical medicine, you have to diagnose it, and with the process of exclusion, and on the basis of the case takings, the real case takings, what happens, how is the history of the present illness, so the evolution of the disease. These are the form of your basis of your diagnosis. So it is one type of inflammatory destructive lesion in the cartilaginous structures, and asymmetric one, and in 85% cases it is migratory one, and seronegative arthropathy is very common. Around 40% of cases is associated this relapsing polychondritis. 40% of cases is associated with rheumatoid arthritis, SLE, cancers, or hematological disorders. So this is not that in 60% cases it is independently, it can happen, it can occur in the economy. But around 40% cases it is mixed with RA or SLE or cancers or hematologic disorders, which are very common. Now, seronegative spondyloarthropathy. This is very important. Very important. Seronegative SSA, seronegative spondyloarthropathy. Because in most of the time, we have observed that there are symptoms of arthritis. The patients are talking about the pain and stiffness, but you can't find anything. So all the cases, whenever you are not finding anything, it may not be a case of rheumatoid arthritis. You are not finding the symmetrical small joint involvement. You are not finding the systemic manifestations. But arthritis or arthralgic pain are there, and there is nothing in the laboratory. And it is not that everything is psychological. Not from the psychological point. Even if from the psychological point of view, the pain will not last for months after months. So whenever the pain is there or redness is there, something you are observing, that something patient is in sick, but you are getting nothing. Seronegative spondyloarthropathy is your answer, is your reply for the diagnosis. So what are the seronegative spondyloarthropathy? Ankylosing spondylitis, reactive arthritis, enteropathic spondylitis, under which Crohn's disease, ulcerative colitis, and all those have relation with HLA-B27. You know HLA-B27, it is not only with ankylosing spondylitis, it is also with reactive arthritis. It is also in Crohn's disease or ulcerative colitis. These are RA factor negative. Oligoarthritis or asymmetrical. Enthesitis, it is also important because I have, in my personal experience, this you can find the patients with enthesitis. Previously, it was said the enthesitis is very much common to HIV positive patient. No, it is also positive to syphilitic patient, but we have seen that the syphilitic prone patient with non-HIV, they are not reactive to HIV or any syphilis, but the syphilitic predominance is there. From homeopathic point of view, they will give you the symptom of this enthesitis, and with the familiar aggregation, extra-articular manifestations. So in this seronegative spondyloarthropathy, it is not only the joint that is affected or the pain you can see, you also to consider the whole body. There may be only red eye, there may be only pain in the cartilage, there may be the pain in the form of intercostal neuralgia like pain, there may be pain in certain one tendon, but it may be the sign of your autoimmunity mediated disorders and seronegative spondyloarthropathy. So think of SSA. First of all, ankylosing spondylitis, chronic low back pain in young adults, generally worse in the morning, progressive limitation of back motion and of chest expansion. Even the chest cannot be expanded, the limitation of movement is there, and transient 50% or persistent 25% peripheral arthritis. For the time being, it may be, in most of the cases, it is transient, 50%, and in only 25% cases, it is persistent peripheral arthritis is going on with ankylosing spondylitis. But anterior uveitis, very, very common. HLA-B27 positive and anterior uveitis, and with the bamboo spine. These are the characteristic triad of ankylosing spondylitis. Diagnostic radiographic changes in the sacroiliac joints. I have already told the bamboo spine describes late radio. You don't expect that from the very beginning the X-ray of the ankylosing spondylitis will give you bamboo spine. It is the late appearance of the spinal column in which vertebral bodies totally become fused, and patient will give you the symptoms of that fused vertebra also. Negative serological test for RA factors and anti-CCP antibodies. Both the cases, the RA factors and anti-CCP, these will become negative in case of ankylosing spondylitis. HLA-B27 is the most helpful when there is intermediate probability of disease, but I must say that HLA-B27 remain positive only 65% to 70% cases, even less than that. But you can find ankylosing spondylosis patient with HLA-B27 negative also, and you will find patient also with HLA-B27 positive, but they are not giving the symptoms which they should provide you. They are not in the pain, they are not in the very much discomfort, but they having HLA-B27 positive. But if the epigenetics, if the accessory circumstances, if the mental makeup of the patient going worse, then these HLA-B27 positive will act as one of the predisposing factors, and then the symptoms may develop. I have seen plenty of patients with HLA-B27 positive but not giving symptoms of any ankylosing till date, as because their mental makeup, their accessory circumstances, their family environment, their office environment, everything is going good, going fine. So it is not that not flare up, it is in the latent state, but whenever anything will happen, then these HLA-B27 will act as one of the disposing factors. Psoriatic arthritis, another one. Psoriatic precedes onset of arthritis. You must remember it is very important that psoriasis precedes onset of arthritis. It is not that first arthritis will occur and then psoriasis will occur. In the psoriasis patient, all the symptoms of silvery scaling, the skin symptoms, psoriatic in the extensor surface, even in the reverse psoriasis. Usually in the reverse psoriasis, psoriatic arthritis is not seen. But in whatever cases I have seen of psoriatic arthritis, all in the extensor surface. But first of all, there is the skin symptoms, then the arthritic symptoms. And the arthritis usually here again asymmetric with sausage appearance of fingers and toes. Polyarthritis that resemble rheumatoid arthritis also occur. Whenever it is the matter of asymmetric, whenever it is a matter of something zigzag, whenever we think of trypanosoma pallidum, we think of some little lightning that of syphilitic, the syphilis of the medicine disease, and also the syphilitic predominancy, the syphilitic, the dynamic pathology of homeopathic philosophy of the syphilitic concept. So whenever you will be thinking anything asymmetric, anything in the form, in the face, in the mouth, in anything asymmetric, that may be a clue to find out the syphilitic predisposition of the patient or syphilitic dyscrasia from the dynamic pathology point of view, which cannot be judged by the modern parameters. It is a unique weapon, the dynamic weapon, I must say, but it should be also explained with the time. It should be also explained in the light of genetic science. Sacroiliac joint involvement common. Ankylosis of the sacroiliac joint may occur. Radiographic findings is a very characteristic pencil in cup deformity. This is the characteristic of our psoriatic arthritis, and relative lack of osteoporosis. Relative lack of osteoporosis. So in psoriatic arthritis, you don't expect so much osteoporosis, which is very common to osteoarthritis. Very common with the density of the bone, the osteoporosis, which is not very common in autoimmunity mediated arthritis in all, especially in case of psoriatic arthritis. But bony ankylosis, asymmetric, these I have seen in most of the autoimmunity mediated arthritis, the asymmetric pattern and the ankylosing pattern. So whatever is going to be deformed, it will remember you about the syphilitic predisposition. Not to all, but in most of the cases. And again, you can see a classical characteristic of atypical syndesmophytes in case of ankylosing. It's a very, very characteristic, these syndesmophytes. This is one latest observation. This is the from paper just 15 days back, not 15 days back, only 10 days back. Diet rich in sugar and fat leads to disruption in the gut's microbial culture and contributes to inflammatory skin diseases such as psoriasis. So whatever fast food we have been consuming right now, from the pizza to everything, to all the chickens, etc., and everything in the fast food, this diet rich and sugar and fat leads to disruption in the gut's microbial culture. So there is a connection. There's a connection with the gut's bacteria. You just think the second one. Research shows that switching to a more balanced diet restores the gut's health and suppresses inflammation. So don't think that the gut's bacteria, all the gut's microbial culture, these are only for your bowel movement, only for your regular bowel movement, whether you are constipated, whether you are dysentery, whether the loose diarrhea, chronic diarrhea. No. These microbial culture of the guts that may be related to your autoimmunity mediated arthritis, that may be related to your autoimmunity mediated skin symptoms like psoriasis. So it is very important your diet. The secret to healthier skin and joints may reside in gut microorganisms. And whatever I am telling, it is not that I am whimsically I am telling or on the basis of intuition I am telling. It is on the basis of research papers. We have the references and the very basic references, and these references having, I have gone through it, 117 references on the basis, and all within 1 year. On the basis of that 117 references, these observations made. So there are direct, we may take the cause and effect relationship with the gut bacteria with the formation of psoriasis, not only psoriasis, because I am talking about arthritis. It is also related to joint pain and inflammation. It is related to mass inflammation. Right now, we are going through the pandemic, and you know the COVID-19, the inflammation, even if it is chronic acute form, whenever it is going to the chronic stage or after the recovery of the pandemic, the most of the patients have been suffering from the inflammatory stage, which is persisting. That may be in the axial, that may be in the arthritic spine form, that may be in the gastritis form, that may be in the chest form, but something chronic inflammation is going on. So if additionally you will not take care of your food and you are consuming more sugar and fat and fatty foods with all the preservatives, that may be the triggering factors for all the inflammations. Since bacteria in the gut may play key roles in shaping inflammation, the researchers wanted to test whether intestinal dysbiosis affects skin and joint inflammation. Very important one. Why it is very important? Whenever I was going through these papers and I was thinking that how wonderful our homeopathic philosophy and our materia medica, etc., that we have the bowel nosodes and we have the symptoms. Even we have not used it. Most of the bowel nosodes, whatever my knowledge is concerned, apart from the dysentery co, psychotic co, bacillus number 7, and in few cases proteus, most of the bowel nosodes are not in use. And if you go through the symptomatology of these bowel nosodes, you can find most of the symptoms are from these joint inflammation, these skin symptoms, etc., with the affinity, characteristic affinity, or differs from one to another. So right now I can remember one of my very senior professors. Now he is no more, of my older college, Homage Homeopathic Medical College. I have seen in most of the cases of rheumatoid arthritis, like or any arthritic pain, he usually prescribed dysentery compound. And whether we were astonished why dysentery compound is prescribing, or why even psychotic co like that. It is, we know that from the acute form there are very many medicine like Nux vomica, like macrotin, all the amoebiasis or amoebiasis related chronic low backache. These medicines are very much effective, but the direct research shows that these gut bacteria may be very much related to your autoimmunity mediated any type of inflammations and even the skin manifestations. So these are very, very encouraging. We have to not lot of research on this part of bowel nodules also, and we have to not only confined to only few of these. There are so many. We have to search out that which bowel nodule may be very much efficacious in this type of chronic inflammations. Now, reactive arthritis. This is the form. Now, I must say that this is the time when reactive arthritis is going on in most of the patients after viral this pandemic, whether is COVID positive or even silent asymptomatic COVID positive. So, oligoarthritis, one spelling mistake is there. Conjunctivitis, urethritis, and mouth ulcers. These are the most common features. So, there will be arthritis in the oligoarthritis, but conjunctivitis, urethritis, and mouth ulcers are the most common features, and usually these arthritis follow dysentery or a sexually transmitted infection. Whenever it is written usually follow dysentery, you just think of our Metriomedica, how wonderfully our Metriomedica from abrotenum to calibichromicum, how wonderfully it is written that rheumatism alternate with dysentery, or after suppression of these can occur. So already we have gems of symptoms. It is not only confined to your abrotenum or calibichromicum. It may be a many more. If you go through, if you hunt Metriomedica and repertory rubrics, we may get lot. So we have these weapons, but we not use it, or we have not gone through it. HLA-B27 positive in 50 to 80% of cases in case of reactive arthritis. Muscle soreness. This is from a very recent research papers. Muscle soreness and achy joints are common symptoms among COVID-19 patients. But for some people, symptoms are more severe, long-lasting, and even busier, including rheumatoid arthritis flares, autoimmune myositis, or COVID toes. A new has confirmed and illustrated the cause of these symptoms through radiological imaging. Imaging illustrates severity and long-term prognosis of COVID-19 related muscle and joint pain. What the researcher said, Dr. Swati Deshmukh, we have realized that the COVID virus can trigger the body to attack itself in different ways, which may lead to rheumatological issues that require lifelong management. You just think it is the lifelong management. You just think it is not for it is the lifelong management. So it is very important. We have realized that the COVID virus can trigger the body to attack itself in different ways. It's a wonderful one. I think, as per researcher, it's important to differentiate between what the virus causes directly and what it triggers the body to do. So one is that virus causing direct destruction or direct whatever pathology is occurring, and another, it is acting as triggering factor. So whenever it is acting as triggering factor, then the rheumatological expert should be consulted. But whenever it is direct the virus is affecting, then you have to go through all the pathological part, what destruction the virus can make with the all radiological imaging, all the blood tests, etc. So you have to rightly diagnose that what is the role of the virus for forming your this rheumatic arthritis or rheumatoid arthritis or any form of arthritis after this COVID infection. This is the recent research just 3 to 4 days back. Now, another one, arthritis and inflammatory intestinal disease. It is very much related. 1/5 of patients with inflammatory bowel disease, IBD, have arthritis, which complicates Crohn's disease somewhat more frequently than ulcerative colitis. There is non-deforming asymmetric oligoarthritis of large joints in which activity of joint disease parallels with bowel disease. And second form of arthritis is spondylitis indistinguishable from ankylosing spondylitis. This is the second form of arthritis is spondylitis, which is indistinguishable from ankylosing. You can't. So it is also very important one you should consider. Infectious arthritis, I will go very fast. This is a septic arthritis, very common inflammatory monoarticular arthritis, infection with causative organism, and the anti-infection, anything whenever you will taking the medicine, anti-infection that will do good. Gonococcal arthritis, Purulent monoarthritis also monoarthritis, characteristic lesion, symptoms of urethritis. We know we can think of thuja, we can think of bedridden, we can think of cannabis sativa, we can think of our good antipsychotic, even the causticum. It is a very good one. Viral arthritis. This one is very good. I must say, viral arthritis. Parvovirus B19 causes an acute polyarthritis in 50 to 60% of adult cases. And arthritis, this viral arthritis can mimic rheumatoid arthritis. The very neonates or the young physicians, even the very experienced physician, they will be in very much in a fix that whether it is of rheumatoid arthritis. But rheumatoid arthritis will not resolve within several weeks. But viral arthritis will resolve within several weeks. It may take 3 months, but it will ultimately resolve. So self-limited polyarthritis is very common in acute hepatitis B infection and typically occur before onset of jaundice. So we must know that hepatitis B, this type of arthritis may happen. Tuberculous arthritis, patient usually presents with again the monoarticular arthritis lasting for weeks. Hips and knees are most commonly affected joints, and diagnostic procedure choice is synovial biopsy in case of tuberculous arthritis. Arthritis in sarcoidosis, 10 to 35% arthritis in sarcoidosis ranges. Knee and ankle are most commonly involved joint, and distribution is polyarticular and symmetric. Sarcoid arthropathy associated with erythema nodosum. Erythema nodosum, you can remember the rheumatic arthritis, the erythema nodosum. So erythema nodosum can be found in many autoimmunity mediated disorders. The sarcoidosis is one of them, the erythema nodosum. Arthritis associated with systemic disease and other arthritis like acromegaly arthropathy. Excessive production of growth hormone along with insulin growth factor 1 stimulates proliferation of cartilage, periarticular connective tissue and bone. Presented with osteoarthritis, back pain due to spine hypermobility and carpal tunnel syndrome. Almost 25% patients exhibit Raynaud's phenomenon. Arthropathy with hemochromatosis, 40 to 50% cases, it may be first clinical presentation of hemochromatosis. You think the patient has been suffering from hemochromatosis, the first presentation, 40 to 50% cases, arthropathy. So symptoms mimic osteoarthritis. Whenever it is not very easy to say casually that you have been suffering from osteoarthritis. So hemochromatosis, the first manifestation in 50% cases may be only arthritis. So we must know this. Hemophilic arthropathy. Spontaneous hemarthrosis is a common problem and can lead to deforming arthritis. Radiography joints reflects the stage of disease. In early stage, there is capsule distension. In later stage, juxtaarticular osteopenia, marginal erosion. Late in disease, features like OA is seen. Neutropathic joints disease, this is a Charcot joint we know, is progressive destructive arthritis associated with loss of pain sensation and proprioception or both. Whether loss of pain or whether proprioception or both. And neuropathic arthritis is encountered most often in patients with DM, diabetic mellitus, with an incidence of 0.5%. Hypertrophic osteoarthropathy and clubbing, HOA, is characterized by clubbing of digits and is more advanced stages by periosteal new bone formation and synovial effusions. It may be primary or familial, may be benign, it may start in childhood. And secondary HOA is associated with intrathoracic malignancies, suppurative, and some hypoxic lung disease, congenital heart disease also. Now, some radiculopathic disorders in arthritis. Radiculopathic disorders, I must say something because radiculopathy arthritis is very much common to lumbar and cervical vertebra also. So, what are the radiculopathy? The radiculopathy commonly present with tingling, tickling, prickling, pain, weakness, numbness, and paralysis. What are the causes of this radiculopathic pain? There may be intervertebral disc prolapse. There may be herniation of gelatinous part of nucleus prolapsus, common in C5 to C6 or C6 to C6, C7, and disc between lumbar 5 and S1. Two type posterolateral and central posterior. So clinical feature pain, tingling, numbness, lumbar scoliosis, free lateral and restricted forward movement, muscle wasting. And what we should do, the brace, spinal jacket, continuous or intermittent traction or this is the management. These are the management. You can see the normal disc, you can see the degenerative disc, you can see the bulging disc, you can see the herniated disc, you can see the thinning disc, and you can also see the disc degeneration with osteophyte formation. These are the different forms. And under degenerative joint disorders, you can find osteoarthritis, seropositive spondyloarthropathy, rheumatoid arthritis, seronegative spondyloarthropathy, under which ankylosing spondylitis, reactive arthritis, enteropathic spondylitis, under which Crohn's disease and ulcerative colitis. So I will not repeat this one. Spondylosis, when osteoarthritic changes occurs in zygopodial joint, it is called facet syndrome. The foramina of exit, whenever there is narrowness of the foramina and the nerve root compression, then the radiculopathic pain will occur. On a Paget's disease, this is the plastic and clastic activities occurs together. In the Paget's disease, this is osteitis deformans, and 27% presents with LBP. Male is to female ratio is 3:2. Lumbar spinal stenosis. It is mostly male patients are sufferer and older than 60 years, presenting symptom often back pain whenever it is radiating to buttock and thigh. This is very important. Whenever the radiating pain is buttock and thigh, it is the very warning sign that there may be spinal stenosis, and diagnosis is best confirmed by MRI. Even surgical procedure, in many cases, surgical procedure is advised by the doctors. Vertebral body compression fracture, which is called whiplash injury. Up to 50% of patients reporting whiplash injury acutely have persistent neck pain over 1 year later. They have experienced the neck pain even after 1 year later. Pott's disease, the tuberculosis of the thoracolumbar vertebra. Commonest site is dorsolateral region, T10. Tuberculosis of the body, tuberculosis of the appendages. You can see the tuberculous metaphysitis, tuberculous osteomyelitis, tuberculous periostitis. And tuberculosis of appendages, you can find lamina, transverse process, pedicle, and spinous process in the Pott's disease. What are the clinical features? Tingling type back pain, military attitude, always military attitude, kyphosis or gibbous, tenderness, paraspinal spasm, and cold abscess. Coin test positive on examination. This is the very often this kyphosis, gibbous, or military attitude, and coin positive. These are the Pott's disease. X-ray of the spine shows narrowing of the disc space, wedging of the vertebral body, and rarefication of the adjacent vertebra, cold abscess on soft tissue. From X-ray of the spine, you can see it. It is MRI in all cases not required. ESR will be very high. ESR will be very high. Compression due to extradural mass. Whenever there is extradural mass, the compression will be there, and the radiological pain will be there. There may be nerve root tumor, that may be extramedullary, that may be intramedullary. Another condition, that is amyloidosis. Whenever there is a deposition of this amyloid, that also may cause this radiculopathic pain. Insoluble polymeric protein fibrils in tissues and organs. Amyloid diseases are defined by the biochemical nature of the protein in the fibril deposits and are classified according to whether they are systemic or localized, acquired or inherited, and by their clinical pattern. Diabetic radiculopathy. It is a syndrome characterized by severe disabling pain in the distribution of one or more nerve roots. Fortunately, diabetic polyradiculopathies are usually self-limited and resolve over 6 to 12 months. Mononeuropathy presents with pain with molar weakness and in the motor weakness and the distribution of a single nerve. Diabetic radiculoplexus neuropathy, diabetic amyotrophy, or Burns-Garland syndrome. 1/3 of patients. Typically, patients present with severe pain in the low back, hip, and thigh in one leg. Characteristic: polyradiculopathy starts in both legs at the same time. It is a very characteristic. Polyradiculopathy starts in both legs at the same time. So it is a diabetic radiculoplexus neuropathy, very rare one. Lab diagnosis is CSF protein elevated, ESR elevated, nerve biopsy characteristic. Now, what are the infections which is related to arthritis? It may be Lyme disease, it may be herpes simplex virus, it may be cytomegalovirus, it may be lymphogranuloma virus, it may be due to syphilis, it may be due to schistosomiasis, it may be due to Gnathostoma spongiarum. So if it is Lyme disease, Borrelia, it is very important because the elevated protein serum Lyme antibody titer and Western blot confirmation, history of tick bite or appropriate exposure history, erythema chronica migrans, skin rash, arthritic radiculopathy. Bell's palsy may happen and multiple sclerosis like syndrome may happen. I will skip this one. This Nathostoma spingerium is eosinophils, mononuclear cells, peripheral eosinophilia, history of eating raw fish. It is very common in Thailand and Japan, not in India, because raw fish is very much they consume Thailand and Japan. Herpes simplex virus type 1, type 2, mucocutaneous anogenital transmission affects the dorsal root ganglia, producing pain, cold sore, herpes labialis, especially in case of active and recurrent type. Cytomegalovirus spread through the saliva, urine, semen, genital secretion on through the vertical infection. Immunocompromised patient may suffer more. It may cause radiculopathy on suffering on affecting on spinal cord. Schistosomiasis, parasitic infestation. S. mansoni is the causative organism. Egg of the parasite may deposits in the spinal cord and presses the root and causes radiculopathic pain. These are all radiculopathic pain. Syphilis, I have already told, the trypanoma pallidum. Now come to the method of history taking of a case of pain. First of all, what is the site? Conventional method, we have to go through the distribution, character of pain, duration, magnitude, change, anything change, posture, changing with the pain modalities, exclusion of more sinister pathology, evaluation of psychosocial elements, etc., etc. So from the homeopathic point of view, what kind of pain, what sensation exactly, was it that occurred on this spot, where was the precise spot, did the pain occur in its fits and by itself at various times, was it continued without intermission, how long did it last, at what time of the day or night? These are all the questions we may think of. The what we must remember one thing, that the radicular pain that results from a radiculopathy should not be confused with referred pain. Is very important. So what is radicular pain? Which are mainly neuropathic pain, as they are produced due to nerve root compression. And what is referred pain? Mainly is it nociceptive pain, as they are due stretching of the viscera and pain in the area of same root valve. So these are the nociceptive versus neuropathic. You can see the characteristic in the nociceptive: aching, localized, sharp, squeezing. But whenever it is neuropathic, shooting, radiating, stabbing, burning, electric like. You can remember the phytolacca, the electric like pain. Nociceptive, again, the modalities. In the nociceptive part, movement aggravates and compensation to stretching ameliorates pain. But in case of neuropathic pain, constant, independent to movement, but change of position may increase or decrease pain. The injury, post-operative pain, visceral pain, toothache, all are nociceptive pain. Neuropathic pain, radiculopathy, peripheral neuropathy, shingles or cancer pain. These are all neuropathic pain. So these are all examples. Now sciatica, very common, very common. It is even the sciatica may be known to very common people. They can use the term. The term sciatica described as a symptoms of leg pain and possibly tingling, numbness, weakness that originates in the lower back and travel through the buttock and down the large sciatic nerve in the back of the leg. Now radiculopathy and sciatica. Another word for the nerve root is radicular nerve. And when a herniated disc or prolapsed disc presses on the radicular nerve, this is often referred to as a radiculopathy. Thus, a physician might say that there is herniated disc at the L4, L5 level, creating an L5 radiculopathy or L4 radiculopathy, depending on where the disc herniation occurs, to the side or to the back of the disc, and which nerve root is affected. The lay term for a radiculopathy in the low back is sciatica. Again, the lay term it is for the radiculopathy in the low back is sciatica. Sciatica characterizes by one or more of the following symptoms. What are the following symptoms? Constant pain only one side of buttock or leg, pain that is worsened in sitting, burning, tingling down the leg, weakness, numbness or difficulty on moving the limb, a sharp pain that makes difficult to stand up or to walk. What are the investigations of radiculopathy? X-ray of the spine, temporal evolution, magnetic MRI, T2WMR neurography, the electrodiagnostic evaluation, the nerve conduction studies, the needle electromyography, discography, the intradiscal pressure is recording after injection of contrast materials. This is discography. This is one paper in which it is from Radiological Society of North America. This is very recent one. A novel outpatient procedure offers lasting pain relief for patients suffering from moderate to severe arthritis in their hip and shoulder joints. What they are doing by the radiological imaging, this Dr. Gonzalez have been studying the application of a novel interventional radiology treatment. What is the name of that radiology treatment? Is very new. It is not common in India. Even it is in America. It is just research papers published. It is called as cooled radio frequency ablation, CRFA, to achieve pain relief. In the how it is achieved, the procedure involves the placement of needle where the main sensory nerve exists around the shoulder and hip joint. The nerves are then treated with a low grade current known as radio frequency that stuns them, showing the transmission of pain to the brain. So it is a new method. It is a new method just to palliate the pain from the Radiological Society of North America. The musculoskeletal disorders, whatever we are talking about the arthritis, but it is now at the challenge to the profession. It is the burden. It is a growing burden to our profession, which we may neglect, but we should not neglect. The policymakers should consider these musculoskeletal disorders as one of the most important burdens in the human society, because these musculoskeletal disorders affect muscles, tendons, ligaments, bones, joints, can severely affect individuals' physical and mental health, and they are especially prevalent among aging adults. For the analysis, researchers examined data from the Global Burden of Disease Study 2017, which assessed the extent of disease and injuries across 21 regions and 195 countries and territories from 1990 to 2017. And it is found that all the conditions, the musculoskeletal disorders included RA, OA, low back pain, neck pain, gout, all other related arthritic conditions. And it was found that approximately 1.3 billion prevalent cases and 121,300 death due to musculoskeletal disorders in 2017 only, as well as 138.7 million disability adjusted life years. So whenever you are sick, whenever your movement is restricted, so you are confined, so your mental makeup also will be decreased and you will be becoming a sick person. So we have to consider this from very serious point of view. A new study published in Arthritis Care and Research has examined patterns of 20. It is another foundation, also based on several research papers, that 24-hour physical activity and your sleep these are the two most important factors in the development of rheumatoid arthritis and knee osteoarthritis. You would think it is not only consideration of rheumatoid arthritis. You may see that it is a disease affected with the mental conditions, with the our environmental or accessory circumstances or the epigenetics like that. But it is the knee osteoarthritis also, which is very much related to your physical activity and sleeping pattern. Whenever your sleeping pattern is disturbed, you may be a patient of musculoskeletal disorders in the long run. If your physical activities is not very much routine like, if it is too excess, then it may occur your knee osteoarthritis. If it is too less, it may occur also a form of arthritis due to less movement also. So a balancing from the excess and with the routine type, we have to make a balance. So these are the findings of European Congress of Rheumatology 2021. The COVID-19 vaccine is safe for people with rheumatic disease. One observation. It is found that COVID-19 vaccine, the rheumatic diseases, the patient has been suffering from rheumatic diseases. Lot of patients, a lot of samples are taken, and it is found that COVID-19 effectively safe. But Israeli researchers, one of the company's vaccine, they have found that there are something autoimmune and inflammatory rheumatic disease may occur from one vaccine, and that's why that vaccine as now is banned or it is in modification. So they have found something, Israeli researchers, in which this chronic inflammation and autoimmune arthritis they have found after the vaccination. Now, third point, among rheumatoid arthritis patients, the two drugs, modern medicine drug, specifically they mentioned these two drugs, rituximab and JAK inhibitors, are linked to worse COVID outcomes. Whatever COVID deaths happen within the rheumatic patients, they have been taking these two drugs. It has been observed, is an observational study. Number 4, rheumatic disease patients are generally not at increased risk for contracting COVID-19 according to the latest EULAR recommendation. There is European Congress of Rheumatology. So, rheumatic disease, but it except the patients who have taken all two types of drug of modern medicine, they are very much susceptible to even the death. People with inflammatory arthritis have been dealing with sleep issues during the COVID-19 pandemic. Again, the patient having rheumatic or inflammatory arthritis, they have been suffering with sleep issues, insomnia may be there, sleeping rhythm is disturbed. This is established data during COVID-19 pandemic. It takes longer for all our European Congress rheumatological observation on the basis of their research during this pandemic. It takes longer for axial spondyloarthritis to get diagnosed than other inflammatory disease. Despite advancement made in whatever we have made, the progress, the advancement in the MRI, in all the techniques, in all the diagnostic models, but till date, the axial spondyloarthropathies, we diagnose it very late in comparison to other. In case of this COVID-19, the axial spondyloarthritis is in rise, and it has been observed that we cannot diagnose in a correct time. It is taking too much time to diagnose that yes, the patient has been suffering from axial spondyloarthropathies, because no such specific diagnostic tool criteria we have invented till date, or whatever we have invented, that is not sufficient to make it a very quick diagnosis to axial spondyloarthropathy. Another observation: weight may impact pain and stiffness for axial spondyloarthropathy patients. So whenever there is obesity, or whenever patient is very sick and thick, very thin, very weak patient, but suddenly gain weight, he or she may develop the axial spondyloarthropathy. So, loss of weight, your BMI index is very much marker of your axial spondyloarthritis, axial spondyloarthropathy, which is in rise after COVID-19. New treatment recommendations for psoriatic arthritis emphasize matching therapies with patient-specific domains. I must here, it should be redlined. It is at per European Congress of Rheumatology 2021. Not a single homeopath was there. But it was totally man of modern medicine, and they have found that the treatment recommendation of most of the arthritic patients will be patient specific, will be personalized. It is not the fixed one drug will be given to all rheumatoid arthritis, will to all osteoarthritis patient. It is the what is the routine, what we should the treatment approach to a patient. It should be individualistic orientation, and the mapping, the planning, the treatment protocol will be made on the individual based. European Congress 2021 Rheumatological Associations, their advice. Maintaining a healthy weight may help prevent gout. Also, in case of gout, hyperuricemia patient, the most of the gout patients having high weight. So, to reduce weight, and the gout may not be requiring any medicine. These are all observations. Again, these are observations. The exposure to cigarette smoking in childhood increases the risk of RA later in life. This is observation of European Congress, not on the basis of pandemic COVID-19, it is, but in their Congress. It's very important one, the second one, polypharmacy in rheumatoid arthritis is associated with being less likely to achieve remission. No effect. Whenever you are giving polypharmacy, it is not from homeopathic point of view, from modern medicine point of view, you are giving polypharmacy in the form of multivitamins, you are giving immunosuppressive drug, you are giving hydrochloroquine. At a time, polypharmacy is of no effect in case of remission of pain in case of RA. Seropositive RA patient, I already told earlier, the seropositive RA patients had better retention on the biological abatacept and were more likely to get to remission than seronegative patients. Whatever the medicines they have been taking, whatever the prognosis they have been showing, in seronegative patients, it is much less in comparison to seropositive. Seropositive patients are giving good response to the treatment. to all the responses. Whatever management you are giving counseling, you are giving all, you are encouraging patient by the physical mental counseling process. You are taking care of the epigenetics, you are taking care of the accessory circumstances, you are taking care of physical therapies, everything you are doing. But all the RA positive patients, only the autonuclear antibodies, the autoantibodies positive patients are giving good response. And which is important, that ultimate goal, what they have written, the ultimate goal of treatment for inflammatory rheumatic disease is personalization. Personalization. So it is the basic philosophy of homeopathy. We feel proud to be a homeopath, that our concept of this philosophy, that the concept of individualization, to treat the patient, not the disease, the patient in the disease, not. So we have to diagnose the patient in the disease condition. So if I diagnose the patient with all its generalities, with all its past history, with all its background, with all its accessory circumstances, etc., then we have already diagnosed the man. Now you have to see that diagnosed man in the disease conditions, what they are showing. So the parts, and on the basis you have to make your treatment plan protocol. Now, the modern medicine also, they are telling that inflammatory rheumatic disease, our answer is only personalization, providing the most effective therapy for each person based on their unique traits. Unique traits, miasmatic dyscrasias, if I alter this one, with the unique traits with miasmatic dyscrasias and needs, what they needs, what they want to be cured in the disease, what are to be want to be cured, the person, the very persons, what he want, what are the points he want to be cured, that should be diagnosed with the dynamic pathology, with the acute observation, with the sound sense or sound knowledge of practice of medicine, clinical medicine, for reaching to the simillimum. You see, the knee osteoarthritis is linked with depression and anxiety. This is another research papers, and this is also the observation of Euler, European Congress, American Rheumatological Congress, European Rheumatological Congress 2021, that the osteoarthritis of the knee is linked with depression and anxiety. And whoever is comorbidity like high cholesterol or hypertension linked with worse osteoarthritis. Osteoarthritis treatment preferences differ between black and white patients. It is that data shows that black people with OA are less likely to have joint replacement surgery despite having more severe arthritic symptoms. The blacks having more severe symptoms, but they are not going through the replacement surgery. But the white with the less symptoms, they are going to the replacement surgery. It is also their observation. But observe on the basis of their, it is not on the basis of the intuition, it is based on the papers, and there are references, so many references. Homeopathic concept of disease, it is well known to all. It is well known to all of us. The very basic concept, the development of one dyscrasia we have inherited, and the new dyscrasia developed on the basis of environmental, genetic factors, disease, psychology, and etc. etc. This is the epigenetics, the concept of that miasmatic diagnosis, which can narrow the field of search of medicines. All three chiasms are responsible to develop any degenerative disease. So the basic miasmatic dyscrasia are there, but the manifestations differ, where destruction predominant, another proliferation predominant. So these are the miasmatic theory. We are all well aware about this, that degenerative disease. SORA is a perturbation of nutrition. Psychosis compels it to accumulate debris, which should be eliminated. And syphilis cause it is degenerate. Infiltration of inflammatory deposits which are permanent. It is not only psychotic, it is also syphilis. The syphilitic miasm, the stitching, shooting, lancinating, the periosteum, the sphere of action, surface overlying the long bone, syphilitic miasm, the night aggravation, change of weather, cold, damp aggravation, amyloidation from warm application, from rubbing, with the general pathology of psychosis, inflammation, infiltration of inflammatory deposit. The worst form of inflammation can be seen in psychosis. It can also form violent palpitation, beating of the whole body. Stiffness, soreness, lameness, shooting or tearing pain, the character of psychosis, pain, and the sphere of action, muscles, joints, fingers, pain due to chalky deposition of the bone. Aggravation, approach of a storm, damp, humid atmosphere, amyloidation moving by rubbing, stretching, dry, fair weather. Sore neuralgic pains are most common numbness of the extremities with tingling in the fingers. This is the one book, The Rheumatic Remedies, H.A. Roberts, published in April 1939. In the preface of the Metra Medica, wonderful quotation. Such remedies are indicated if and when they are proving have developed like symptomatology, regardless of the syndrome to be treated. Remedies have their own sphere of action. In the form, this evaluation of symptom, capital, small capital, italics, Roman, the remedies are arranged in alphabetical order. And the concomitant part, that's why I put this slide. The concomitant part is very important, most important. You see the example of syphilinum. Utter prostration and debility in the morning, weakness on waking, afraid to go to sleep because of fear of terrible weakness on waking, poor reaction, chronicity, great weakness with few symptoms. Pain gradually increases and gradually decreases. The more intense the pain, the more the remedy indicated. How wonderful example of syphilinum in the concomitant part. This is from Metra Medica Pura. From symptomatology of 379, rheumatic pain in the back and limbs, sharp stitches in the bend of the middle joint of the index, rheumatic pain in the foot. We are all, but without the characteristic symptoms, without the heat of upper parts of the body, coldness of the lower, without the offensiveness of arnica, without the chilly patient, we cannot think of arnica. Again, the bryonia, whatever in Metra Medica Pura, in the wrist joint, pain as if sprained or dislocated at every movement, somewhat hot, pale swelling of the distal joint, the little finger, beard shoots it on moving the finger and pressing on it, great weakness in the thighs, stitches in the knee, but the characteristic keynote aggravation of any motion, all types of pains of bryonia relieved by pressure. These are very common. So, whatever disease we should consider, whatever disease, we should not go away from the characteristic of the drug. It may be bryonia, it may be anything. Ledampal, it is not only that the gouty treatment will be ledampal, but the keynote symptoms, the rheumatism beginning in lower limbs, ascends, aggravation, warmth of bed, motion, evening, cold, amelioration, okay. But the swelling and tensive and shooting pain in the also knee when walking, it is not only in the great toe, even pressure on both shoulder joint, aggravation by movement. So these are from Metra Medica Pura. Little bit, I have taken 4 or 5 only. Guecum in the left side of the nape of the left side of the back down into the sacrum, a rheumatic stiffness, frequently recurring sharp stitches on the top of the right shoulder, tearing in the right forearm extend it into the wrist joint. But the keynote symptom like rheumatic pain aggravated from heat and motion, with the sore throat as concomitants, we can think of offensive sweat, offensive urine, typical syphilitic background. These are our guecum, like mercurius, typical syphilitic background, excessive sweat, characteristic tongue. But we cannot forget that mercurius has also can produce the symptoms of rheumatism. Rheumatic pain from nape, neck, fingers are asleep in the morning, swelling with proximal finger joint. So we must consider the common symptoms, but we should give importance to the characteristic of the mercurius are there or not. Either you cannot give on the basis of only number 689, 690 rheumatic pain, the stitching or migrating pulsatilla, wandering pain from one or other, but the typical uh, characteristic of the pulsatilla, like mildness, the fidgety, the indecisive. You cannot give these on the basis of number 689 and 690 if the patient's characteristic is like Nag's type. The mentality is like Nag's type. It will not work. So, with the common symptoms, but keeping intact the typical characteristic of pulsatilla, it is very important. In any good drug, in any good big drug, we must think of even the Rastrux also. Rastrux also, the typical findings of tongue, the typical modalities of Rastrux, these are very important, very important. Rutagraviolence, you can see the backache relieved by lying on the back. You can remember the last line of the Allen. The typical affinity with the periosteum, with the small joints, with the wrist, ruta. Even the sulfur, we should not forget sulfur. Pain over the sacrum when walking, not when sitting. Sulfur standing is the worst position. It is not even only standing is the worst position. It is due to some pathology. something pathology due to related to arthritis. So standing is the worst position. It may be due to many other cause, but you think here as because right now I am talking on arthritis, so I will talk that the pathology basic pathophysiology of sulfur, one of the characteristic from the rheumatic conditions, from the arthritic condition. Rheumatic pain in left shoulder. I have seen one patient, a typical sulfur patient, and with all the characteristic of sulfur, and the only one-sided pain from here to here, one-sided pain, no boils, no abscess, but a typical pain. And we are confirmed about the neuralgic pain, whether chamomilla, because patient is very much restless. But on the basis of characteristic of sulfur, we prescribe sulfur 201 dose, and with good result. Totally the pain disappears. So sulfur also may be indicated, but we cannot go away from the characteristic of sulfur. The same thing applied to thuja also. Thuja, you can see all the drawing pain. Thuja is a very good drug from gonococcal arthritis, you know. But it is, if in the form of dynamic pathology, you should not consider gonococcal, etc., etc. The fear of something will break down. It is something numbness. All the symptoms, all those symptoms may be found in disease also. In very many diseases, you can find the numbness or something. There is nothing in the pain or something. Always, I am working on something soft materials like that. These are the typical fixed ideas may have the patients. So your picturizations of the patients with the materia medica, matching of the symptoms, these are very important whenever you will be reaching to your simulacrum. Calibicromicum, something I've already mentioned, that rheumatism alternate with gastric symptoms, the colchicum. Typical colchicum are so much abused in homeopathic profession. In most of the cases, whenever there is pain, just to relieve pain as painkiller. But colchicum should be given on the basis of its indication, like syphilinum is very less used. Syphilinum. It is very much abused in shoulder rheumatism, but in all type of rheumatic arthritis, in if the patient is of syphilitic based, we can think of, apart from not only from rheumatism of the shoulder joint, in any arthritic pain we can think of syphilinum, we can think of tuberculinum with its characteristic of cosmopolitan habits, desire for milk, aversion to meat, all these things. Even the medroinum, wonderful drug in the PUD, it is a wonderful drug of prolapse intervertebral disc. It is wonderful drug. It is. And three or four slides, three or four slides, three or four slides of radiculopathy related rubrics in OE Boric's repertory. I will give three or four slides only. Chapter generative spinal bifida. You can see bryonia, calcarea, phosphoridum, tuberculinum. So it is congenital disorders. You can't think that spinal bifida will be cured by this, but if the patient suffer from due to these type of congenital disorders, any type of pain or any discomfort, that can be cured by these drugs. Even the carry spots, there are so many medicines from curvature. You can see the spinal wound, ruta symphytum. So the single remedy rubrics a very important one. You can see this one: gout, rheumatism, syphilis, kali, iode, meserium, phytolacca, zoster after meserium, morphinum, spinal cord concussions, arnica, bellispar, hypericum, even physostigma. Rubrics from Kent's repertory, we can think of two drugs, calcarea and rustox, that is the lifting from. But we must mention that if we go to another repertory like Patak's repertory or any other repertory, we can get 5 to 6 more drugs. Even the strontia carb, even the calcarea carb is very good drug. This is a chronic effect of the chronic stretching and lifting from. Not only rustox, calcarea, ruta also there, strontia carb also there. In the cervical region, you can see only one drug, that is meserium. It is also from Kent repertory. It is, I can show one, that is dislocation in last lumbar vertebra, sensation of only one drug sanicula. Only one drug sanicula, that is the dislocation in the last lumbar vertebra, sensation of. It is only one drug sanicula. Extremities, perspiration, foot, injuries of spine in nitric acid. That is, so these single remedy rubrics are very important. These are also give our enthusiasm to go to Materia Medica to read, etc. And these are from Robert Sensation as if, very good book. You can plenty of sensation as if, and there are so many single remedy rubrics that is dislocated sensation as if back, belladonna is there, in cervical vertebra, synaveris is there, fire burning in upper spine, tuberculosis is there, galvanic battery attached in spine, agaricus is there. So many rubrics in the upper and lower extremities in this book, also the chapter. And it is repertory to the rheumatic remedies, H. Roberts. Any remedies in the Metromedica, or for that matter, any substance that may not have been proven as yet, may be indicated. It is written in the forward. But whatever I have experienced, that all the remedies we have already proven remedy good, and Hahnemann himself proved all the 9900 remedies, all those remedies, they are very good. If we go through very deep, very longitudinal study, we may go to this Metromedica, and through the repertory we can think of repertory. So the conceptual image, whatever, will be through repertory and Metromedica. If we develop, and if we have a very good knowledge of clinical medicine, then only the matching will be perfect one. And also we should remain updated, because what is happening, what are the newer features, what are the newer investigations, these we should know everything, because it is a dynamic subject, the clinical medicine. Everything is occurring nowadays. It is written that knee osteoarthritis is related from anxiety and mental disorders. More than 100 years or 50 years ago, if you say that it is mad, whatever he is talking. But right now it is telling, it is written in the book, and after research study, lot observational study, it has been found. So the concept of this individualistic concept, the miasmatic dyscrasia, with the dynamic pathology concept, with the concept of single remedy concept, de-addiction. Now they are considering the drug de-addiction, no polypharmacy. They are talking of single molecules. So we are already exposed to this type of single medicine, minimum dose, with the individualistic concept, dynamic pathology, with the changing medicines, with the changing accessory circumstances from epigenetics, from the miasmatic concept to genomic sequence. These updations are required for these. But the basic things, the basic philosophy remain ever constant. The basic philosophy, never, nothing new will happen. The same syphilinum will be given as given 200 years ago. Nothing new syphilinum you are giving. Okay, you may after the proving in very many regions, you may get few more symptoms from the syphilinum. It may happen, or the few symptoms may disappear from the new provings. But that proving also to be held with very cautiously, and with the trustworthiness of any research. The most important thing is trustworthiness, and just be confident on yourself. So we all will remain confident, and we all remain trustworthy to our profession. With this, thank you all for patience hearing, and we will meet again in another webinar. Thank you.
Thank you so much, sir. Professor Dr. Rajat Chattopadhyay, sir, Principal and Administrator of the Calcutta Homeopathic Medical College and Hospital, for such a practical-oriented presentation. Now, I would like to request Professor Dr. Kishore Kumar Noshkar, sir, to keep his opinion regarding the topic and conclude the session, as well as vote for thanks. Sir.
Thank you, Dr. Pratima. First of all, I want to thank our respected principal, sir, for his elaborate presentation with latest updates related to serological activities, socio-psychological involvement of relevant chronic diseases, even present pandemic, the inflammatory bowel disease, the reactive arthritis like Reiter's syndrome, even other septic arthritis, gonococcal arthritis, tubercular arthritis, different viral arthritis, parasitic arthritis, etc., etc., etc. Everything related to arthritis with their latest updates have been elaborately described. And really, it was a great presentation. Not only that, a relevant relation with gut bacteria, with our management through bowel nosodes. And also, he has described the recent treatment procedure with taking radio frequency wave, a new method of palliative treatment. And not only that, the role of polypharmacy, smoking, psychological state of the patient, the concept of individualization or personalization in the remission of this type of diseases. I think it can help to take the topic for our PGTs for their dissertation in future. Fantastic point-to-point relation with the drugs which are useful in these various types of arthritis. And not only that, description of the drugs from Materia Medica Pura and other Materia Medicas, and even from the repertories. Each drug wonderfully picturized. I think it will be a complete book of arthritis with complete homeopathic therapeutics and miasmatical analysis. Thank you very much, sir. Thank you again for sharing your such a vast experience on this topic. And now I want to thank our first speaker, Professor Dr. Debashis Biswas, for his nice elaborate presentation on leukorrhea and other abnormal vaginal discharges. It covers the etiological factors, the character, relevant investigations with non-medicinal and medicinal management. Thank you, Dr. Biswas. And before conclusion, I want to thank everybody, the participants, all faculty members, especially Dr. Naveen Singh for his important background activities, our PGTs, especially Dr. Pratima, and our beloved UG students. Thank you all. Thank you very much. Now we conclude this session. Thank you.
Thank you, sir. We are ending the live broadcast here.
Thank you, Dr. Pratima.
Thank you, sir.
Nice coordination. Thank you.
Thank you, sir.